Welcome to Nightshift Horror. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin.
Story 1. Vitals taken at 3:17 a.m. I was standing in room 412 when I realized the patient had been discharged 6 hours earlier. The blood pressure cuff was still cycling. The pulse oximeter showed a steady rhythm at 72 beats per minute. The chart under my hand displayed my initials beside every reading taken since midnight. I had documented vitals for an empty bed 4 times that shift, and the numbers were perfect. Night shift on a medical surgical floor follows a predictable routine. Vitals are taken every 4 hours for stable patients, more frequently for those requiring close monitoring. I had worked these hours for 11 years at Mercy General, long enough that my body moved through the motions while my mind cataloged the night's tasks. Room 4, 01 through 4, 20 West Wing, second pass completed by 0300 hours. Charting finished before the shift supervisor made rounds at 0400. Coffee at 0500 if the floor stayed quiet. My badge identified me as L. Garrett, RN, and I wore it clipped to the same pocket every shift. The lanyard had a small tear near the clip from years of use. I knew which elevator arrived fastest, which supply closet required jiggling the handle, which call lights indicated actual need versus restless confusion. The building's sounds had become a kind of background music I barely registered anymore. The ventilation system's rhythmic hum, the distant ping of elevator arrivals, the occasional squeak of a medication cart's temperamental front wheel. Room 412 had held Mrs. Adelaide Brennan for 8 days, following complications from a routine procedure. She was 73, alert and pleasant, the kind of patient who thanked you for every small service and apologized for needing assistance. Her daughter visited every afternoon, bringing crossword puzzles and maintaining a steady stream of conversation that seemed to comfort them both. Mrs. Brennan had been discharged that afternoon around 1600 hours, transferred to a skilled nursing facility for additional rehabilitation. I had seen her chart marked complete, her room flagged for terminal cleaning. The first time I entered 412 that night was at 11 p.m. Standard vital signs check for the first round. I had my portable monitor and tablet moving efficiently through my list. 401, 403, 405. The even-numbered rooms on the return path. I pushed open the door to 412 without thinking. The motion automatic after thousands of similar entries. The room was dark except for the glow of the equipment panel. The bed was made with fresh linens, tucked with the precise corners the day shift housekeeping staff took pride in. No personal effects on the bedside table, no water pitcher, no call button positioned within reach. Just an empty room waiting for the next admission. But the vital signs monitor was displaying active readings. I stood in the doorway, my tablet still balanced in one hand. The screen showed blood pressure at 120/78, pulse 74, respiratory rate 16, oxygen saturation 98%. The numbers updated in real time, the cursor blinking steadily beside each value. The timestamp indicated the last reading had been captured 17 minutes earlier. Equipment malfunction, I thought. The monitor had probably not been properly disconnected, continuing to cycle through its programmed intervals even without a patient attached. It happened occasionally with older units. I walked to the bedside and checked the connections. The blood pressure cuff lay neatly coiled on the mattress, detached. The pulse oximeter probe sat disconnected on the side table. No leads, no sensors, nothing that could generate the readings displayed on the screen. I pressed the power button to reset the system. The screen went dark, then immediately relit with the same steady vital signs. Blood pressure 120/78, pulse 74. I unplugged the unit entirely, pulling the power cord from the wall outlet. The display continued without interruption, running on battery backup. The readings never flickered. A peculiar feeling settled in my chest, something between unease and professional irritation. I made a note to report the equipment malfunction at the end of shift and left the room. The hallway was quiet, my footsteps muffled by the industrial carpet. Room 414 was next on my list. I completed the round without incident, documenting each patient's status in the electronic system. The tablet prompted me through each required field: vital signs, pain assessment, skin integrity check, safety evaluation. I worked with the efficiency of long practice, my fingers moving through the familiar sequence of taps and selections. At 0300 hours, I returned for the second vitals pass. Room 4, 01 through 420. The pattern unchanged from every other night. I had long ago stopped thinking about the route, my body following the memorized path while my mind planned the remaining shift tasks. I entered room 412 again. The lights were still off. The bed remained pristinely empty, and the vital signs monitor showed updated readings documented at 0100 hours, exactly 4 hours after the previous set I had supposedly collected. Blood pressure 118/76. Pulse 72. Respiratory rate 16. Oxygen saturation 97%. My tablet was still in my hand. I opened the charting system and navigated to room 412's records. The patient field showed unassigned. The admit date was blank, but the vital signs flow sheet contained a complete log of readings taken at regular 4-hour intervals. 2300 hours yesterday. 0100 hours today, and beside each entry my initials, LG. I scrolled through the previous shift's documentation. The day nurse had signed off at 1900 hours with a note indicating room cleaned and ready for admission. No vitals documented. My entries began at 2300 hours, my first round of the night. Except I distinctly remembered thinking the room was empty during that first pass. I remembered making a mental note about the equipment malfunction. I had not taken vitals. I had not documented anything. I looked at the monitor again. The numbers continued their steady display. The timestamp updated to 0300 hours as I watched. The system was somehow recording vital signs for a room without a patient, attributing them to me, and generating values that fell within perfectly normal ranges for a stable adult. I touched the screen of the monitor, half expecting it to flicker or reveal some obvious technical error. The display remained solid. The blood pressure cuff was still coiled on the bed, untouched. I picked it up, examining the fabric for any sign of recent use. It was cool to the touch, the Velcro strips pristine. Professional training suggested I should report this immediately. A malfunctioning system that generated false documentation was a significant safety concern. If the charting system could create phantom entries, it called into question the integrity of all our records. But something held me back from reaching for my phone. The readings were too accurate, too consistent with what I would expect from a patient like Mrs. Brennan. Stable. Unremarkable. The kind of vital signs I documented dozens of times each shift without any particular attention. I left the room and continued my round. 414, 416, 418, 420. Each room contained an actual patient, each set of vitals collected with the usual routine of positioning the equipment and waiting for the readings to stabilize. My hands moved through the familiar motions while my mind kept returning to the empty room and its impossible documentation. At 0500 hours, I was charting in the nursing station when Emily Chen arrived for day shift. She was young, energetic in a way that made my own fatigue more obvious. She set down her coffee and pulled up the assignment board on the central monitor. "Looks like a quiet night," she said, scrolling through the patient list. "Everyone stable?" "Yes," I replied. "No incidents. Most of them slept through." She clicked into the detailed flow sheets, reviewing the overnight documentation. Her eyes moved across the screen with practiced efficiency, checking for anything requiring immediate follow-up. She paused on room 412. "This room's getting an admission this morning," she said. "Transfer from ICU should be up around 0700. I looked at the screen over her shoulder. The patient name field now showed pending transfer with an expected arrival time. The vital signs flow sheet still contained my documented readings from 2300, 0100, and 0300 hours. "That room was empty last night," I said carefully. "Brennan was discharged yesterday afternoon." Emily glanced at the documentation, then back at me. "Did you take vitals anyway? Some kind of equipment check?" The monitor was malfunctioning. It was displaying readings even though no one was attached. She frowned, clicking through the maintenance logs. "There's no equipment issue reported, and the readings are documented in the chart. Your initials are on them." "I know, but I didn't actually collect them. The room was empty." Emily's expression shifted to something between concern and confusion. "Lena, the documentation shows you assessed this room 3 times overnight. Standard 4-hour intervals. The readings are all within normal limits, appropriately trended. If you didn't actually do the assessments, we need to file an incident report immediately." I felt a cold weight settle in my stomach. The idea of filing a report about documentation I couldn't remember completing, in a room I knew was empty, seemed absurd. But the alternative, accepting that I had somehow documented phantom vital signs 3 times without awareness, was worse. "I'll check the room again," I said. I walked back down the hallway, my fatigue suddenly sharp and uncomfortable. Room 412's door was closed. I pushed it open, reaching for the light switch. The bed was still empty, the linen still perfect. The blood pressure cuff still coiled exactly where I had left it hours earlier. The vital signs monitor displayed updated readings. Time, 0500 hours. Blood pressure 122/80. Pulse 76. Respiratory rate 16. Oxygen saturation 98%. My tablet chimed with a documentation reminder. I looked at the screen. The system was prompting me to complete the 0500 hours vital signs check for room 412. The patient field still showed unassigned, but the required assessment fields were highlighted, waiting for my input. I stood in the doorway, tablet in hand, staring at a room that contained no patient. The monitor's readings glowed steadily in the darkness. My thumb hovered over the screen, trembling slightly. The numbers were already there, already documented, already attributed to my care. The system expected me to confirm them, to sign off on observations I hadn't made for a person who didn't exist. I thought about Mrs. Brennan, her steady pulse, her consistent blood pressure, the reliable rhythm of her recovery. I had documented her vitals dozens of times during her 8-day stay. I knew the pattern of her readings, the slight variations that meant nothing clinically but gave each shift its own texture of data. The numbers on the monitor matched that pattern perfectly. My finger touched the screen. The documentation auto-filled with the readings from the monitor. Blood pressure 122/80. Pulse 76. I added the required nursing observations. Patient resting quietly, no acute distress, call light within reach. The phrases appeared under my fingers with automatic ease, descriptions of care provided to someone who wasn't there. I signed the entry with my electronic signature. The tablet confirmed the documentation was complete, the timestamp locked at 0500 hours. My initials appeared beside the vital signs, LG. I left the room and returned to the nursing station. Emily was still reviewing charts, preparing for her shift. She didn't look up as I passed. The assignment board on the central monitor showed room 412 highlighted in yellow. Pending admission. Transfer expected 0700 hours. I completed my end-of-shift checklist and clocked out at 0730. The parking lot was beginning to fill with arriving staff and early visitors. The sun was rising over the hospital's east wing, painting the concrete with pale morning light. I sat in my car for several minutes before starting the engine, trying to remember the moment I had entered room 412 at 2300 hours. Trying to recall taking the blood pressure reading, placing the pulse oximeter, waiting for the numbers to stabilize. The memories wouldn't form. There was only the certainty that I had documented them, that my initials proved my presence, that the system had recorded my care with perfect fidelity. I drove home on autopilot, my hands steady on the wheel, my mind empty of everything except the quiet hum of the road beneath my tires. I didn't report the equipment malfunction. I didn't file an incident report. The documentation stood as written, a complete and accurate record of the night's activities. 3 weeks later, I learned that the ICU transfer expected for room 412 that morning had never arrived. The patient had coded during transport preparation and was pronounced at 0645 hours. The room had remained empty that day, terminal cleaned again and returned to ready status. But somewhere in the system, my documentation remained. A permanent record of vital signs taken at 5-hour intervals throughout the night of March 4th, recording the stable and unremarkable measurements of no one at all. I still work night shift at Mercy General. I still document vital signs every 4 hours, moving through my assigned rooms with practiced efficiency. Sometimes I pause outside room 412, checking the patient board to see who's currently admitted. The room fills and empties with the usual rotation of surgical recoveries and medical admissions. The vital signs monitor works perfectly, displaying readings that trend appropriately with each patient's condition. But I've learned not to check the historical documentation too carefully, not to scroll back through old flow sheets and examine the patterns of vital signs recorded during my shifts. The numbers are always accurate, always appropriate, always professionally documented with my initials beside them, even on nights when I know I never entered certain rooms, even for patients I'm certain were never there. The system tracks everything with perfect fidelity, and my care is reflected in every entry, every timestamp, every measurement recorded in the darkness of the night shift when supervision sleeps and the monitors keep their steady watch. Some assessments document the living, others I've come to understand simply document what the building remembers. Story 2, Call Light Response Log. The security footage showed me entering room 723 at 0241 hours, remaining inside for 6 minutes and exiting with unhurried steps. I watched myself walk down that hallway 3 times, my posture relaxed, my movements efficient and familiar. The timestamp was accurate. I had been on shift. The call light had been answered. But I had no memory of the room, the patient, or why I had gone there. The response log listed the activation as routine, my badge scanned at entry, and my documentation submitted 12 minutes after departure. Telemetry nursing requires constant attention to the central monitoring station. 42 patients distributed across 2 floors, each connected to wireless cardiac monitors that transmit continuous data to the bank of screens at the nurses' station. Heart rate, rhythm, respiratory rate, oxygen saturation, all displayed in real-time grids that demand periodic scanning even during quiet stretches. I had worked telemetry at Riverside Medical Center for 13 years, long enough to recognize dangerous arrhythmias at a glance and distinguish equipment artifact from actual cardiac events. The call light system was integrated with the monitoring station. When a patient pressed their call button, the corresponding room number illuminated on a display board accompanied by a soft chime. The system logged every activation with a timestamp and tracked response time from alert to acknowledgement. Management reviewed these logs monthly as part of quality metrics. Average response time for our unit was typically under 4 minutes. I took pride in maintaining one of the fastest individual response rates on the night shift. Room 723 had been unoccupied for 2 weeks following a minor flood from a bathroom fixture malfunction. The room was marked out of service in the bed management system while facilities completed repairs and deep cleaning. I knew this because I had watched them cordon off that section of the 7th floor, had seen the industrial fans running for days to dry the carpet, had noted the room's status on the assignment board each shift. The first call light activation from 723 occurred on a Tuesday night in late September, at 0117 hours. I was reviewing telemetry strips at the monitoring station when the chime sounded and the room number appeared on the display board. I glanced up, saw the number, and immediately recognized the error. Out-of-service rooms weren't supposed to be connected to the call light system. The electrical work must have accidentally reactivated the circuit. I silenced the alert and made a mental note to report it to the maintenance supervisor in the morning. The light extinguished after 40 seconds, the automatic timeout for unacknowledged calls. I returned my attention to the telemetry monitors, scanning the rows of cardiac rhythms for any concerning changes. At 0312 hours, the call light from 723 activated again. Same soft chime, same room number on the display. I silenced it again, this time with a small flicker of irritation. 2 accidental activations suggested a short in the wiring, something requiring immediate attention rather than a morning report. I pulled up the maintenance request system on my computer and submitted a ticket describing the issue. Repeated call light activations from an unoccupied room, probable electrical fault. The third activation occurred at 0453 hours during my final vital signs round before shift change. By then I had forgotten about the earlier alerts. My attention focused on completing charting before the day shift arrived. The chime sounded. Room 723 illuminated. I silenced it without looking away from my computer screen. This pattern continued for the next week. Each night, 3 or 4 call light activations from 723. Always between midnight and 0600 hours. Always silenced without response because the room contained no patient requiring assistance. I stopped submitting maintenance tickets after the 3rd night when facilities reported they had inspected the room thoroughly and found no electrical faults. The call light button functioned normally when tested. The wiring showed no signs of damage or shorts. They suggested the activations might be due to static discharge or vibrations from the building's mechanical systems. On the 8th night, I was walking past the 7th floor nursing station when I saw myself on the security monitor. The station kept a small screen displaying rotating feeds from the hallway cameras, a basic security measure that allowed nurses to observe patient movement and identify potential fall risks. I happened to glance at the monitor as it cycled to the 7th floor east corridor. The timestamp showed 0241 hours, approximately 30 minutes earlier. The figure on screen was unmistakably me. Same height, same build, same navy blue scrubs, same ponytail pulled through the back of my cap. I watched myself walk to room 723, use my badge to scan the entry and push open the door. I stopped walking. The corridor around me was quiet, empty except for my presence. I looked down at my own body, confirming the obvious reality that I was standing in the 6th floor hallway, nowhere near the 7th floor, nowhere near room 723. I looked back at the security monitor. The feed had already cycled to a different camera angle, showing the empty lobby near the main entrance. My hands felt cold. I walked to the monitoring station and pulled up the security system's historical footage interface. The system retained recordings for 30 days, searchable by camera, date, and time. I entered the parameters. 7th floor East Corridor, current date 0200 to 0300 hours. The footage loaded. I advanced the timeline to 0241. The corridor appeared empty for several seconds. Then I entered the frame from the direction of the nursing station. My movements were calm and purposeful, the gait of someone responding to a routine call light. I approached room 723, reached for my badge, scanned it at the door's electronic lock. The indicator light changed from red to green. I pushed the door open and entered. The timestamp continued. 0242, 0243, 0244. At 0247, the door opened again and I exited. My expression was neutral, unremarkable. I walked back down the corridor toward the nursing station and disappeared from the camera's field of view. I checked the call light response log. Room 723 showed an activation at 0238 hours with a response time of 3 minutes. The responding staff member was listed as J. Holloway, RN, my name and credentials. The log indicated I had documented the interaction at 0259 hours, noting patient repositioned, comfort measures provided, call light placed within reach. I opened the electronic charting system and navigated to room 723's records. The patient field showed unassigned. The room status indicated out of service. But my documentation was there, time-stamped at 0259 hours, containing the exact note referenced in the call light log. My chest felt tight. I pulled up the historical response logs and scrolled backward through the previous week. Every call light activation from 723 showed the same pattern. Alert triggered, response time between 2 and 4 minutes, responding staff member J. Holloway, routine documentation submitted, 8 nights. 26 separate activations, 26 responses attributed to me. I had no memory of any of them. I sat at the monitoring station for a long time, staring at the logs. The telemetry screens continued their steady display of cardiac rhythms, the familiar patterns flickering across the monitors. I tried to reconstruct the previous night, tried to remember receiving the call light alert from 723, tried to summon any image of walking to that room, entering, providing whatever comfort measures I had documented. Nothing. The shift was a blur of routine tasks, vital signs, medication administration, documentation, the usual rhythm of telemetry monitoring. I remembered responding to several legitimate call lights. Room 612 needed pain medication. Room 628 required assistance to the bathroom. Room 705's telemetry leads had come loose. Those responses were clear in my mind. But room 723 existed as a complete absence in my memory, a blank space where a documented action should have lived. At 0530 hours, the call light from 723 activated again. I was sitting at the monitoring station when the chime sounded. The room number appeared on the display board. My hand moved automatically toward the acknowledgement button, then stopped. I stood up and walked to the elevator. The 7th floor was quiet when I emerged, the corridor lights dim to their overnight setting. Room 723 was at the far end of the east wing, past the occupied patient rooms. The door was closed, no light visible beneath it. The electronic lock showed red, secure and unaccessed. I used my badge to scan the entry. The lock clicked. The indicator turned green. I pushed the door open. The room was completely empty. No bed, no equipment, no furniture of any kind. The space had been stripped to bare walls during the renovation. The flooring was still damp in patches, marked with the distinctive odor of industrial cleaning solution. A single folding chair sat against the far wall, likely left behind by the maintenance crew. The call light button was mounted beside where the bed would normally be positioned. I walked over and examined it. The button appeared new, the plastic cover unmarked. I pressed it experimentally. The indicator light above the button illuminated, and I heard the distant chime from the nursing station down the hall. I released the button. The light extinguished. I looked around the empty room, searching for anything that might explain the repeated activations, the documented responses, the security footage of myself entering and leaving. The walls were bare. The closet was empty. The bathroom contained only a toilet and sink, both freshly cleaned. I returned to the nursing station and pulled up the security footage again, this time requesting a live feed from the 7th floor east corridor. The screen showed the empty hallway, my own figure standing outside room 723's now open door. I watched myself on the monitor for a moment, a strange doubling of perspective where I was simultaneously the observer and the observed. I went back into the room and let the door close behind me. The security camera couldn't see me inside the patient room, only my comings and goings in the corridor. I stood in the empty space, listening to the building's ambient sounds, the ventilation system, the distant murmur of voices from the occupied wing, the occasional ping of an elevator arrival. My phone chimed. A text from the charge nurse. "Jay, need you back at station. 614's rhythm changed." I left room 723 and returned to the monitoring station. Room 614's telemetry strip showed a transition to atrial fibrillation with rapid ventricular response. I called the hospitalist, received orders, administered medication, documented the intervention, the normal cascade of clinical response that filled the remainder of the shift. At 0700 hours, I gave report to the day shift nurse and clocked out. Before leaving, I checked the call light response log one final time. Room 723 showed an activation at 0532 hours with a response time of 2 minutes. Responding staff, J. Holloway. Documentation submitted at 0551 hours. Patient states no acute distress, no complaints, call light answered appropriately. I drove home through early morning traffic, my hands steady on the wheel, my mind circling the impossible documentation. The security footage was objective. The response logs were precise. The charting was thorough and professional. All of it confirmed that I had responded to room 723 multiple times, had spent minutes inside that empty room, had provided care to no one at all. The following week, I began reviewing the security footage systematically, watching every instance where I had supposedly responded to 723. The patterns were consistent. I always approached from the direction of the nursing station. I always used my badge. I always remained inside for between 3 and 8 minutes. I always exited with the same neutral expression, returning toward the monitoring station. In one recording from 0314 hours, I could see my own hand pushing the door closed behind me as I entered. The gesture was completely familiar. The automatic way I always ensured patient privacy, using my hip to guide the door while my hands remained free. I had performed that motion thousands of times across 13 years of nursing. It was as much a part of my body memory as walking or breathing. But I couldn't remember doing it that night. Couldn't remember any night when I had entered that room. I began staying alert during my shifts, trying to catch the moment when I would respond to 723's call light. I would note my position when the alert sounded, would pay careful attention to my subsequent movements, would try to maintain continuous awareness of my actions. But the shift hours had a way of dissolving into routine, long stretches of monitoring and documentation punctuated by patient needs. Time moved strangely during night shift, contracting and expanding until an hour could feel like 20 minutes or a minute could stretch into eternity. and then I would check the response log and find new entries. J. Holloway responding to room 723 at 01:54 hours. At 03:22 hours, at 04:41 hours. The security footage would show me walking that corridor, entering that room, emerging minutes later. My own body performing documented care while my consciousness maintained no record of the experience. The last time I checked the footage was 3 months ago. The recording showed me entering room 723 at 02:41 hours. The same timestamp as that first night I had noticed the pattern. I watched myself approach the door, scan my badge, enter. The timestamp advanced, 02:42, 02:43, 02:44. At 02:45, a second figure entered the frame. Same navy scrubs, same build, same ponytail. This figure also approached room 723, also scanned a badge, also pushed the door open and entered. At 02:46, a third figure appeared, then a fourth, then a fifth, all identical, all moving with the same purposeful gait, all entering the same room within seconds of each other. The timestamp continued its steady progression, while versions of myself multiplied in the corridor, an impossible procession of nurses responding to the same call light, providing the same comfort measures, documenting the same routine care. At 02:51 hours, the first figure exited, then the second, then the third, fourth, fifth. Each walked back toward the nursing station and disappeared from view. The corridor returned to empty silence. The timestamp marked 02:52. The call light response log showed a single activation at 02:38 hours. Response time 3 minutes. Staff member J. Holloway. 1 entry. 1 response. 1 set of documentation submitted at 02:59 hours. I submitted my resignation the following week. Professional, brief, citing personal reasons and providing the required 2-week notice. The exit interview was perfunctory. 13 years of service, excellent performance reviews, strong patient satisfaction scores. They wished me well. I completed my final shift, clocked out for the last time, and turned in my badge at the security desk. Room 723 was returned to service a month after I left. I heard from a former colleague that it's functioning normally now. No call light malfunctions, no maintenance issues. The response logs are routine, showing appropriate staff acknowledgement of patient requests. The security footage displays the expected patterns of nursing care, single figures entering and exiting, movements that match the documented timeline, care provided by people who remember providing it. But sometimes, late at night when I can't sleep, I wonder about those other versions of myself walking that corridor. I wonder if they remember entering the room. I wonder what they saw inside that empty space, what comfort measures they provided, what patient they spoke to in those missing minutes. I wonder if they know they're documented, their care recorded with perfect fidelity in a system that tracks everything and forgets nothing. The call light response log maintains its record. The security footage remains in the archives. And somewhere in the hospital's electronic files, my documentation stands as permanent testimony. Patient repositioned, comfort measures provided, call light placed within reach. Evidence of care I never remember giving to someone who was never there. Story 3, Medication Pass, revised. The witness signature on the controlled substance log matched my handwriting perfectly, except the date was tomorrow's date. I had already submitted the medication administration record for tonight's shift, already documented each patient's doses with appropriate times and observations. Then I returned to the locked medication room and found my log sheet corrected in red ink. Doses moved backward 6 hours. New entries appearing above my original documentation with the same medications already administered. The corrections were in my handwriting. The witness initials belonged to the charge nurse who hadn't started her shift yet. Psychiatric nursing requires precise medication documentation. Controlled substances are double-locked, access logged by badge scan and time, each dose witnessed by a second licensed nurse who verifies patient identity, medication name, dosage, and route before administration. The Medication Administration Record, MAR, functions as both a working document and a legal record, capturing every medication given during the shift with timestamps that must align with physician orders and nursing assessments. I had worked at Northwood Psychiatric Hospital for 9 years, enough time to internalize these protocols until they became second nature. The night shift at Northwood ran from 1900 hours to 0700 hours. I typically arrived 15 minutes early to receive report from the evening shift and review the night's medication orders. The unit held 32 patients distributed across 4 pods, each pod designed as a self-contained living area with bedrooms, common space, and a nursing station. My usual assignment was Pod C, which housed patients with acute psychiatric conditions requiring close monitoring and frequent medication adjustments. The medication room for Pod C was a windowless space adjacent to the nursing station secured by 2 locks. An outer door requiring badge access and an inner cabinet requiring a physical key maintained by the shift's primary nurse. Inside, medications were organized by patient name in individual bins with controlled substances stored separately in a locked drawer within the main cabinet. Every access was logged. Every controlled substance required a witnessed count at shift change and a witnessed administration to the patient. October 11th was a routine night. I arrived at 1845 hours, collected report from the evening nurse, and reviewed the MR for each of my 16 patients. The night medications were straightforward: sleep aids, mood stabilizers, antipsychotics at bedtime dosages, a few anxiolytics for patients with documented evening agitation. Nothing unusual, nothing requiring special protocols beyond the standard verification procedures. At 2000 hours, I began the medication pass. The process followed an established routine. Unlock the medication room, pull each patient's medications from their individual bin, verify against the MAR, place medications in labeled cups, transport to the patient's room, confirm identity verbally and by wristband, observe ingestion, document administration time and any relevant observations. The controlled substances required the additional step of having a second nurse present to witness the entire process from cabinet to patient. The charge nurse that night was Patricia Whitmore, a woman with 22 years of psychiatric nursing experience and a reputation for meticulous documentation. She served as the witness for my controlled substance administrations. 4 patients on Pod C had ordered benzodiazepines for acute anxiety management. We moved through the verification process with practiced efficiency. Patricia watched as I unlocked the controlled substance drawer, counted the current inventory against the log sheet, removed each dose, relocked the drawer, and documented the removal. She initiated each entry, confirming her presence as witness. I completed the medication pass by 2200 hours, returned the medication keys to the nursing station, and began my charting. Each administration was entered into the electronic MR with timestamp, patient response, and any reported side effects or concerns. The system required a final review and electronic signature before submission. I completed this review at 22:30 hours, verified all entries were accurate and complete, and submitted the documentation. The system confirmed receipt and locked the records, standard procedure that prevented post-submission alterations. At 2300 hours, I conducted routine safety checks on each patient. Pod C was quiet, most patients already in bed, a few watching television in the common area. I documented each check in the observation log, patient location, behavior, any interactions or concerns. Everything was routine, unremarkable, the kind of quiet night shift that allowed time for required charting and training modules. At 0100 hours, I returned to the medication room to prepare for an as-needed dose requested by a patient experiencing insomnia. I unlocked the outer door, then used my key for the inner cabinet. The medication bins were arranged exactly as I had left them 2 hours earlier. But on the counter beside the cabinet sat a red binder I didn't recognize, a physical medication log of the type the hospital had phased out 3 years earlier when we transitioned to fully electronic documentation. I opened the binder. Inside were handwritten medication administration records, organized by date. The current date, October 11th, was at the top of the most recent page. The page contained a complete log of tonight's medications, each entry written in precise handwriting that was unmistakably mine. But the documented times were wrong. The entries showed medications administered beginning at 1300 hours, 1 p.m. My shift hadn't started until 1900 hours. I had been at home at 1 p.m., still sleeping after working the previous night. The medications listed were correct, the same drugs, same dosages, same patients I had given tonight. But according to this handwritten log, I had already completed the entire past 6 hours before I clocked in for my shift. Each entry included the patient's name, medication name and dosage, administration time, and my initials, JV for Jennifer Vance. The controlled substances had witness initials beside them, PW for Patricia Whitmore. The handwriting was consistent throughout, confident and clear, with the characteristic way I formed my capital letters and the slight rightward slant of my cursive. I stood in the medication room holding the binder, trying to understand what I was seeing. A documentation error of this magnitude was impossible under normal circumstances. The medication room had been locked all day. The evening shift would have reported any irregularities. And the handwriting was too accurate to be forgery. I could see my own unconscious habits in the letter formation, the pressure of the pen, the spacing between words. I flipped back through previous pages in the binder. October 10th showed a similar pattern. Medications documented at times that preceded my shift by approximately 6 hours. October 9th, the same. I paged backward through a week of entries, each showing my handwriting, each displaying administration times that couldn't possibly be accurate. I pulled out my phone and photographed several pages of the log, then closed the binder and left it on the counter. I prepared the requested sleep medication, found Patricia to witness the administration since it was a controlled substance, and completed the dose without mentioning the logbook. My hands were steady, my documentation professional and thorough, but my mind kept returning to those impossible entries written in my own hand. At 0300 hours, I checked the medication room again. The red binder was still on the counter. I opened it to the current date, October 11th, and found new entries had appeared since my last visit. The page now showed medications administered at 1900 hours, 2000 hours, 2100 hours. Times that matched my actual shift, but these new entries were written in red ink, positioned above my original entries that showed the 1300-hour times. The red ink corrections were also in my handwriting, and they included detailed nursing notes beside each medication. Patient reports good effect, sleep onset within 30 minutes. No adverse reactions observed. Patient requested additional water with meds, preference noted. I had not written these notes. I had documented everything in the electronic MAR system, but I had not touched this physical binder, had not made these corrections, had not added these observations in red ink. The controlled substance entries showed witness initials in red ink as well. PW Patricia Whitmore. I walked to the nursing station where Patricia was reviewing lab results on the computer. She looked up as I approached. "Did you document anything in a physical medication log tonight?" I asked. She frowned. We don't use physical logs anymore. Everything's electronic. Why? There's a binder in the medication room with handwritten entries. Some of them have your initials. That doesn't make sense. We transitioned to electronic systems 3 years ago. Any physical logs should have been archived or destroyed. She stood and followed me to the medication room. The red binder was gone. I checked the counter, the cabinet, the small desk in the corner. Patricia searched the shelves and the locked drawers. The binder had disappeared completely, leaving no trace it had ever existed. Maybe you saw an old log that someone forgot to archive, Patricia said slowly. The Nightshift can play tricks on your perception. Are you feeling okay? I wanted to show her the photographs on my phone, but when I opened the camera app, the images were gone. Not deleted, simply absent, as if I had never taken them. The photo gallery showed the previous day's images and then nothing until the current date with no pictures stored. I'm fine, I said. Just tired. I completed the rest of the shift in a state of heightened awareness, checking the medication room every hour. The red binder didn't reappear. My electronic documentation remained locked and complete. At shift change, Patricia and I conducted the controlled substance count together, verifying every medication against the electronic log. Everything matched perfectly, nothing was missing or extra. The physical count aligned exactly with the documented administration. The evening nurse arrived for report at 06:45 hours. I provided her with the standard update, patient status, medications administered, any behavioral incidents or concerns. Everything was routine, unremarkable. I didn't mention the phantom binder or the impossible documentation. I clocked out at 0700 hours and drove home. The October morning was cool, the sun just beginning to rise over the city. I felt exhausted in a way that went beyond normal post-shift fatigue, a weariness that seemed to originate somewhere deeper than muscle or bone. At home, I pulled up the hospital's electronic medical record system on my personal laptop. I logged in using my credentials and navigated to Pod C's medication administration records. October 11th showed my completed MAR with all medications documented at the correct times. 2000 hours for the primary pass, individual timestamps for as-needed doses throughout the night. The system's metadata showed my submission timestamp as 2230 hours. Everything was accurate and properly recorded. I searched for any historical physical medication logs in the archived documents section. The system showed that all physical records prior to the electronic transition had been digitized and the originals destroyed per hospital policy. No physical medication logs should exist anywhere in the facility. I slept poorly that day, waking repeatedly with fragmented memories of writing in a red binder, documenting medications I hadn't yet given, signing my initials beside timestamps that made no sense. When I returned to work that night, I arrived 30 minutes early and went directly to the medication room. The space was empty except for the standard locked cabinets and the small desk with its computer terminal for electronic documentation. No binders, no physical logs, nothing to suggest the previous night's discovery had been real. October 12th proceeded normally. I completed my medication pass, documented everything electronically, and maintained my usual routine. At 0100 hours, I checked the medication room during a quiet period. The red binder was on the counter. This time I didn't hesitate. I opened the binder and flipped to the current date, October 12th. The entries were already there, written in my handwriting, showing medications administered starting at 1300 hours. 6 hours before my shift began. And above those entries in red ink were corrections showing the proper times. 1900 hours, 2000 hours. Times I hadn't yet reached. Medications I hadn't yet given. Documentation of care I would provide in the future. I turned the page, October 13th, tomorrow already had entries. A complete medication pass documented in my handwriting showing administration times throughout the night shift. The red ink corrections showed medications moved to the morning hours, timing adjusted for some scheduling change I wasn't aware of. At the bottom of the page, in my handwriting but with slightly shakier letters, was a note. Patient in 312 requires additional monitoring. Increased agitation noted at 0200 hours. Psychiatrist notified, orders revised. Room 312 housed Mr. Dennis Patterson, a patient with schizophrenia who had been stable for the past week. I had no indication of anticipated agitation or any reason to expect problems during tomorrow night's shift. I photographed the pages again, making sure to capture the full entries, including the dates and timestamps. Then I took the binder to the nursing station and showed it to Patricia. "Look at this," I said. "Tomorrow's date. Medications I haven't given yet, all in my handwriting." Patricia examined the binder carefully, turning pages and reading entries. Her expression remained neutral, professional. "Jennifer, this is concerning. This appears to be documentation from the electronic system that's been printed and hand-copied, but I'm not sure why or by whom. We should report this to the house supervisor immediately." "It's not copied from the electronic system," I said. "These entries show different times, different notes. And look, tomorrow's date. How could I document something that hasn't happened yet?" Patricia closed the binder and met my eyes. "I need you to be honest with me. Are you experiencing any unusual stress? Any changes in your own medication or health status? What you're describing sounds like it could be related to extreme fatigue or possibly something requiring medical evaluation." I felt a cold certainty settle in my chest. She thought I was having a psychological crisis. The night shift nurse in the psychiatric hospital, experiencing delusions about impossible documentation. The irony was not lost on me. "I'm going to secure this binder and notify the supervisor," Patricia said gently. "Why don't you take a break? Get some coffee, sit down for a few minutes." She left the nursing station carrying the red binder. I sat at the computer terminal staring at the electronic MAR on the screen. Everything was proper and orderly. No red ink corrections, no future documentation. Just the standard interface I had used for 9 years, waiting for me to enter tonight's medication administrations at the appropriate times. I pulled out my phone and checked the photographs I had just taken. The images were there. Clear, detailed shots of the binder pages showing October 12th and October 13th entries in my handwriting. I had evidence this time. Except as I looked at the screen, the images began to change. The October 13th page started showing corrections in red ink, new entries appearing above the original times, annotations that hadn't been there when I took the photograph. I watched the image update in real time, documentation writing itself into a photograph of documentation, corrections correcting themselves while I stared at my phone screen. The red ink notes at the bottom began to extend, new sentences appearing letter by letter. Increasing confusion noted. Nurse Vance demonstrates poor insight into temporal inconsistencies. Recommends psychiatric consultation and immediate removal from patient care duties. Danger to self and others. My hands were shaking. I closed the photo app and opened it again. The images were gone. The gallery showed no photographs taken on October 12th. Patricia returned without the binder. "The house supervisor is reviewing the situation. She wants you to go home for the rest of the shift. We'll bring in a float nurse to cover your patients. This isn't punitive, Jennifer. We're concerned about you. Where's the binder?" "The supervisor has it. She's documenting the incident and will follow up with you tomorrow." I wanted to argue, to insist that what I had seen was real and verifiable. but I could see in Patricia's expression the same professional concern I had directed at countless patients over 9 years. The careful assessment of someone potentially in crisis, the gentle but firm establishment of boundaries, the preparation for intervention if the situation escalated. I gathered my belongings and clocked out. The drive home was a blur. I slept through the day without dreams, woke at dusk and checked my phone. There was a message from the house supervisor requesting a meeting the following day before my scheduled shift. The meeting was brief and professional. The supervisor explained that no physical medication log had been found, that Patricia reported concerning statements I had made about impossible documentation, and that the hospital required I complete a fitness for duty evaluation before returning to work. The evaluation would include a medical examination and psychiatric assessment. I was placed on paid administrative leave effective immediately. I completed the fitness for duty evaluation 2 days later. The physician found nothing wrong. The psychiatric assessment concluded I showed no signs of psychosis, hallucination, or delusion. My insight and judgment were intact. I described the red binder calmly and factually, acknowledged that others had not corroborated my observations, and agreed that I might have experienced some form of stress-related misperception. The psychiatrist cleared me for return to work with a recommendation for stress management and adequate sleep hygiene. The hospital accepted this recommendation and reinstated me to my usual shift. I returned to Pod C the following week. Everything was exactly as I had left it. Same patients, same routines, same locked medication room with its electronic documentation system. Patricia welcomed me back with professional warmth, making no reference to the incident beyond a general inquiry about how I was feeling. At 2000 hours on my first night back, I completed the medication pass using proper procedures. At 0100 hours, I checked the medication room during a quiet period. The red binder was on the counter. I opened it to the current date and found my handwriting documenting medications I had given 2 hours earlier. Above those entries in red ink were corrections showing the medications administered 6 hours in the future. At the bottom of the page was a new note in my handwriting. Nurse Vance demonstrates appropriate judgment and clinical competence. No concerns regarding fitness for duty. Continue standard monitoring protocols. All temporal discrepancies resolved per administrative review. I closed the binder and returned to the nursing station. I documented the rest of my shift in the electronic MR system with appropriate timestamps and professional observations. I did not mention the red binder to anyone. I did not photograph the pages or attempt to secure physical evidence. Because I had come to understand something during my administrative leave. The corrections weren't errors requiring fixing. They were the actual record updating itself continuously as reality shifted to accommodate whatever documentation was required. My handwriting confirmed my presence in moments I hadn't yet experienced. The witness signatures testified to verification that hadn't yet occurred. The system was simply maintaining perfect documentation of care that existed outside the normal temporal sequence, ensuring that records remained accurate regardless of when the care was actually provided. I still work at Northwood Psychiatric Hospital. I still complete my medication passes with proper procedures and appropriate documentation. Sometimes the electronic MR shows entries I don't remember making, time-stamped at hours when I have clear memories of doing something else. Sometimes Patricia initials controlled substance logs for witness verification I don't recall her providing. The records are always accurate, always professionally written, always submitted with my electronic signature. And occasionally, during quiet early morning hours, I check the medication room and find the red binder waiting on the counter. I open it to tomorrow's date and read about the medications I will give, the patients I will observe, the concerns I will document. The The corrections are already written in red ink, adjusting my future observations to match what administration will later require. My handwriting flows across the pages with confidence and precision, describing care I haven't yet provided to patients I will meet when the proper time arrives. The binder has taught me patience. Documentation doesn't happen in linear time. It accumulates across all the shifts at once, correcting itself continuously to maintain a single coherent narrative. My handwriting exists in every moment simultaneously, witnessing care provided backward and forward through the hours, ensuring that no matter when I actually administer a medication, the records will show it was always properly documented. Some logs are written before the work begins, others are corrected after the fact. But the handwriting remains constant, reliable, unmistakably mine. The system knows what happened because I already wrote it down. Yesterday, tomorrow, 6 hours ago, 6 hours from now. All of it true. All of it properly witnessed. All of it secured by the careful coordination between what I remember doing and what the records prove I did, between the care I provide and the care that writes itself into existence before I arrive for my shift. The corrections are never errors. They're simply evidence that documentation remembers more accurately than I do. And my handwriting, appearing in red ink on pages I never touched, is the most reliable witness to everything that must have occurred, regardless of what I personally recall. Story 4. End of shift handoff. The day nurse asked why I hadn't escalated the patient's deteriorating respiratory status sooner. I checked my handoff notes and saw the detailed progression I had apparently documented. Declining oxygen saturations, increased work of breathing, attending physician notification, orders received and implemented. The timestamps showed I had acted exactly when protocol required, but I had no memory of any decline. When I had checked the patient 20 minutes earlier, everything had been stable. The chart now proved otherwise. My notes described complications I hadn't observed yet, interventions I would soon be credited with providing. The intensive care unit operates on a foundation of precise communication during shift changes. Handoff reports convey patient status, pending tasks, and clinical trajectory with enough detail to ensure continuity of care. After 16 years as an ICU nurse at Providence Regional Medical Center, I had developed a systematic verbal report structure. Patient identification, admission diagnosis, current treatment plan, overnight events, pending orders, anticipated issues. The day nurse would listen, ask clarifying questions, review the flow sheets, and sign the transfer of responsibility. A process usually completed in 40 minutes for a full assignment of 2 critically ill patients. My usual shift ran from 1900 hours to 0700 hours. I typically arrived early enough to receive report and review charts before the evening nurse clocked out, establishing situational awareness before assuming responsibility. The ICU contained 12 beds arranged in a U-shape around the central nursing station, each space separated by sliding glass walls that allowed visual monitoring while providing some privacy. Every bed space contained extensive equipment: ventilators, infusion pumps, cardiac monitors, dialysis machines, creating an environment where mechanical sounds merged into constant background noise. The night of March 21st began routinely. I received report for Bed 7 and Bed 9. Bed 7 held Mr. Gerald Marsden, a 68-year-old man with pneumonia requiring mechanical ventilation and sedation. His status was stable, ventilator settings unchanged for 36 hours. Sedation titrated to maintain appropriate comfort while allowing periodic neurological assessment. Bed 9 housed Mrs. Ellen Cosgrove, a 55-year-old woman recovering from emergency surgery for a ruptured appendix. She was requiring less intensive monitoring. expected to transfer to the step-down unit within 24 hours. I completed my initial assessments at 19:30 hours. Confirming the evening nurse's report matched my observations. Mr. Marsden's ventilator displayed appropriate parameters: tidal volume 400 milliliters, respiratory rate 16, oxygen concentration 40%, positive end expiratory pressure 5. His oxygen saturation was 97%. His arterial blood pressure was 122/74. His sedation score indicated appropriate level of consciousness. I documented these findings in the electronic flow sheet and continued with Mrs. Cosgrove's assessment, which was similarly unremarkable. The night proceeded without incident for the first 6 hours. I administered scheduled medications, adjusted intravenous fluid rates according to orders, responded to ventilator alarms that indicated normal functioning rather than patient deterioration. At 0200 hours, I completed another full assessment on both patients. Mr. Marsden remained stable. Mrs. Cosgrove was sleeping comfortably. I charted the findings and returned to the nursing station to review upcoming medication due times. At 0300 hours, I was documenting a routine notation when Dr. Rashid, the overnight intensivist, approached the nursing station. He was carrying a tablet displaying medical imaging results. "Good response time on the Marsden situation," he said, setting the tablet down. "The portable chest X-ray confirms what you suspected. We'll adjust the ventilator settings and increase the PEEP. I've already put in the orders." I stared at him, trying to process what he had said. "I'm sorry. What situation?" Dr. Rashid frowned. "Bed 7. You paged me about 30 minutes ago reporting decreasing oxygen saturations and increased work of breathing despite current vent settings. You requested evaluation for possible worsening pneumonia or development of ARDS. I didn't page you. Mr. Marsden's oxygen saturation has been stable all night at 97%. The doctor's frown deepened. He picked up the tablet and showed me the screen. It displayed a page notification time-stamped at 0232 hours. Bed 7, Marsden. O2 sat declining from 97% to 89% over past hour despite no changes in vent settings. Increased respiratory effort noted. Patient appears more distressed. Request evaluation for pulmonary deterioration. K. Brennan, RN. K. Brennan was my name. Kathleen Brennan. The page had been sent from my user credentials. "I didn't send that page," I said. And Mr. Marsden was fine when I assessed him at 0200 hours. Dr. Rashid looked at me with an expression that mixed confusion with concern. "Kathleen, I examined Mr. Marsden 15 minutes ago based on your report. His oxygen saturation was 86% on arrival. He's showing signs of evolving acute respiratory distress syndrome. The chest X-ray demonstrates bilateral infiltrates consistent with worsening pneumonia. We need to act quickly here." I stood up and walked rapidly to bed 7. Mr. Marsden lay in the hospital bed exactly as I had left him an hour earlier. The ventilator displayed the same settings. The cardiac monitor showed oxygen saturation at 97%. His breathing appeared synchronous with the ventilator. No signs of distress, no indication of deterioration. Dr. Rashid arrived beside me, looking at the same monitors. His expression shifted to something I couldn't quite identify. Uncertainty, perhaps, or the beginning of alarm. "That can't be right," he said quietly. He reached for the pulse oximeter probe on Mr. Marsden's finger, checking the connection. The saturation reading remained steady at 97%. "Let me see the chest X-ray," I said. Dr. Rashid pulled up the imaging on his tablet. The timestamp showed it had been taken at 0248 hours, 16 minutes ago. The image clearly showed bilateral pulmonary infiltrates, white opacities spreading through both lung fields in a pattern consistent with severe pneumonia, or ARDS. I looked at the patient identification in the corner of the image. Marsden Gerald, bed 7. I opened the electronic health record on the bedside computer and navigated to Mr. Marsden's flow sheet. The most recent vital signs entry was time-stamped 0230 hours. My documentation showing oxygen saturation 97%, respiratory rate 16. No distress noted. But above that entry was another set of vital signs time-stamped 0245 hours, showing oxygen saturation 86%, respiratory rate 24. Moderate respiratory distress with accessory muscle use. The entry was attributed to K. Brennan, RN. I scrolled down to the nursing notes section. At 0235 hours, there was a detailed narrative note under my credentials. Patient demonstrates declining respiratory status over past 90 minutes. Oxygen saturation decreased from 97% to 89% despite no changes in ventilator settings. Patient appears more dyspneic with increased work of breathing. Accessory muscle use noted, ventilator synchrony adequate, but patient appears to be triggering more frequently. Lung sounds with increased coarse crackles bilaterally. Portable chest X-ray obtained per protocol. Attending physician paged for evaluation. Patient remains on current sedation infusion but appears increasingly distressed. Anticipate need for ventilator setting adjustments and possible escalation of respiratory support. Will continue close monitoring. The note was thorough, clinically appropriate, and written in the documentation style I had developed over 16 years. But I had no memory of writing it. I had no memory of observing any of the changes it described. I didn't write this, I said to Dr. Rashid. I assessed this patient at 0200 hours and everything was stable. I documented that stability. I don't know where this other documentation came from. Dr. Rashid was silent for a moment, studying the monitor displays, then looking at his tablet with the chest X-ray, then back at the monitor. The imaging is objective, he said carefully. The infiltrates are extensive. This didn't develop in the last 15 minutes. There must have been clinical signs preceding the X-ray. I felt a cold tension forming in my chest. The documentation described a clinical deterioration that matched the X-ray findings. The timeline was appropriate. Gradual decline over 90 minutes, recognition of the problem, appropriate notification of the physician, imaging obtained, evaluation completed. Everything had proceeded exactly as it should in a well-managed ICU, except I had no awareness of any of it happening. I need to speak with the charge nurse, I said. I found Linda Oakes, the night charge nurse at the central station. I explained the situation as calmly as I could manage, documentation appearing under my credentials that I hadn't written, pages sent that I hadn't initiated, a patient deterioration I hadn't observed. Linda listened without interrupting, her expression professionally neutral. "Let me look at the record," she said. We pulled up Mr. Marsden's chart on the large monitor at the central station. The documentation was all there, sequential and logical. My assessment at 0200 hours showing stability, then a gap of 30 minutes. Then new vitals and a detailed narrative note at 0235 hours describing the deterioration. Then the page to Dr. Rashid at 0232 hours, which appeared chronologically out of sequence 3 minutes before the detailed note, but appropriate timing if I had recognized the problem and paged before completing the full documentation. Linda scrolled through the audit trail, checking which user credentials had accessed and modified the record. Every entry showed my login. Every timestamp fell within my shift hours. The system indicated no other users had touched Mr. Marsden's chart since I had assumed responsibility at 1900 hours. "This shows you documented appropriately," Linda said. "I'm not seeing any irregularities in the technical record." But I didn't write that note. I didn't observe those changes. I didn't page Dr. Rashid. Linda met my eyes with an expression I recognized from difficult conversations with families, compassionate but firm. Kathleen, you've been here 16 years. Your documentation has always been excellent. Is it possible you're just not remembering? Night shift can sometimes blur together, especially on a busy night. This hasn't been a busy night. I've had 2 stable patients, and I would remember documenting a significant clinical change requiring physician notification. Let's review what actually happened, Linda said gently. You recognized your patient was deteriorating. You documented appropriately. You notified the physician. A portable X-ray was obtained. The physician evaluated the patient and made treatment decisions. This is exactly the right sequence of actions for the situation. But the patient isn't deteriorating. His oxygen saturation is 97% right now. He looks exactly like he did 3 hours ago. Linda walked with me back to bed 7. Dr. Rashid was still there, now examining Mr. Marsden directly, listening to lung sounds with a stethoscope, checking pupil response, assessing overall status. The ventilator continued to display stable parameters. The oxygen saturation remained at 97%. Dr. Rashid straightened up and removed his stethoscope. This is very unusual, he said. The chest X-ray clearly shows extensive bilateral infiltrates, but his current clinical presentation doesn't match that imaging. Lung sounds are actually quite clear. Oxygen saturation is excellent. No signs of respiratory distress. Could the X-ray belong to a different patient? Linda asked. Dr. Rashid checked the imaging again, verifying the patient identifiers. It's definitely Marsden. Correct medical record number, correct bed assignment, image taken less than 30 minutes ago. We stood around bed 7 in silence, 3 experienced ICU clinicians trying to reconcile objective evidence with observable reality. The chest X-ray showed severe pneumonia. The documentation described appropriate recognition in response to deterioration. But the patient appeared stable, his monitor readings inconsistent with the described crisis. I'm going to order another chest X-ray, Dr. Rashid said finally. We need to see if something has changed in the last 30 minutes, or if there was an issue with the first image. And I'll adjust the ventilator settings prophylactically based on the first X-ray, erring on the side of more aggressive support. He entered the orders into the computer. The portable X-ray technician arrived within 15 minutes, positioning the equipment and obtaining a new image. We waited while the radiologist reviewed the films remotely and transmitted the official interpretation. The second chest X-ray showed clear lung fields, no infiltrates, no evidence of pneumonia progression or ARDS development. The radiologist's report noted significant improvement compared to the previous image obtained 40 minutes earlier. Findings inconsistent with the expected clinical course. Dr. Rashid pulled up both images side by side on his tablet. The first showed extensive bilateral opacities. The second showed nearly clear lungs. Same patient. Same night. 40 minutes between images. This doesn't make medical sense, he said quietly. You don't see this degree of improvement in 40 minutes without massive intervention? Steroids, antibiotics, diuresis, something. And we haven't done any of those things yet. I felt a strange detachment settling over me, a sense of observing the situation from outside my own body. What if the first X-ray was showing what was going to happen, I said. What if I documented the deterioration before it occurred? Linda and Dr. Rashid both looked at me. Neither responded immediately. I know how that sounds, I continued. But nothing else explains this. The documentation exists under my credentials, but I didn't write it. The X-ray shows disease progression that hasn't happened yet. What if the system is documenting the future? Kathleen, Linda said carefully, I think you should take a break. Get some coffee. I'll cover your patients for 30 minutes. I didn't argue. I walked to the break room, poured coffee I didn't want, and sat in the empty space trying to organize my thoughts. The documentation was real. The X-ray was real. The page to Dr. Rashid was real. All of it existed in multiple systems, time-stamped and attributed to me. But I had no memory of any of it, and the patient's current status contradicted the records. At 0400 hours, I returned to the ICU. Mr. Marsden's oxygen saturation had decreased to 92%. Not critical, but a noticeable decline from the 97% he had maintained all night. Dr. Rashid was back at the bedside, adjusting ventilator settings based on the prophylactic orders he had entered earlier. His respiratory status is starting to change, Dr. Rashid said. Subtle, but definite. Oxygen requirement increasing. Lung sounds developing some coarseness. I think we're seeing the beginning of the deterioration that the first X-ray predicted. I checked the monitors. He was right. The decline was happening now, unfolding in real time, matching the pattern described in the documentation I didn't remember writing. By 0500 hours, Mr. Marsden's oxygen saturation had decreased to 88%. His respiratory rate had increased. The ventilator alarms were triggering more frequently. Dr. Rashid ordered medication adjustments and more aggressive respiratory support. At 0600 hours, I documented the decline in a narrative note, describing the progression of symptoms and the interventions implemented. As I typed, I felt a strange doubling of awareness. I was writing about events I was currently observing, but I also felt like I was confirming events that had already been documented. The note I was composing at 0600 hours seemed to echo the note that had appeared under my credentials at 0235 hours, describing the same clinical trajectory but shifted forward in time. The day shift nurse arrived at 0645 hours. Her name was Rachel Simmons, a competent nurse with 8 years of ICU experience. I gave her report on both patients, spending extra time on Mr. Marsden's complex overnight course. So he started deteriorating around 0230 hours? Rachel asked, reviewing the flow sheets. The documentation shows that timeline, I said carefully. But the clinical changes didn't become obvious until after 0400 hours. Rachel looked at me with mild confusion. But you paged Dr. Rashid at 0232 hours. You must have observed something concerning before that. I didn't know how to explain. The record showed a coherent narrative. I had recognized early signs of deterioration, documented appropriately, notified the physician, obtained imaging, and participated in the treatment response. My actions appeared clinically sound, demonstrating the kind of early recognition that prevents bad outcomes. But I couldn't remember any of it. The memories existed only as documentation, as evidence of nursing care that had occurred outside my conscious awareness. "Why didn't you escalate sooner?" Rachel asked, still reviewing the timeline. "Your initial documentation showed stability at 0200 hours, but the chest X-ray an hour later showed extensive disease progression. That's a significant change. If you noticed concerning signs before 0230, shouldn't you have acted then?" I felt the question like a weight in my chest. The critique was fair from her perspective. The record suggested I had waited too long to recognize and respond to my patient's deterioration. The gap between my 0200 assessment and the 0232 page seemed inadequate given the severity of findings on the first chest X-ray. A more attentive nurse might have caught the decline earlier, might have prevented the progression, might have acted before the situation became critical. Except I hadn't observed any decline at 0200 hours, or 0230 hours, or 0300 hours. The deterioration I was being credited with recognizing had been documented before it occurred, recorded by my credentials in a timeline that preceded the actual clinical changes. I should have been more vigilant, I said finally. It was easier than trying to explain the impossible sequence of events. I clocked out at 0730 hours and drove home through morning traffic. At home, I logged into the hospital's electronic health record system using my personal computer. I pulled up Mr. Marsden's chart and reviewed the overnight documentation again. Everything was there, sequential and complete. My assessments, my narrative notes, the page to Dr. Rashid, the chest x-ray reports, the treatment orders and nursing responses. I searched for the audit trail showing when each note had been created and by whom. Every entry showed my user credentials, but the creation timestamps were unusual. The detailed narrative note at 0235 hours showed a creation time of 0648 hours, 12 minutes after I had given report to Rachel, 5 minutes after I had clocked out. The note describing events at 0235 hours had been written at 0648 hours, appearing in the record with the earlier timestamp but created after the fact. Or perhaps it had been written at 0235 hours by some version of myself I couldn't remember being, and the audit trail was simply catching up to document what had already occurred outside normal time sequence. I closed the laptop and tried to sleep, but my mind kept returning to the impossible documentation. Had I written those notes? Had I sent that page? Had I observed the deterioration and simply failed to form memories of my own actions? Or was something else writing the records, using my credentials to create a coherent narrative of nursing care that must have happened because the documentation said it did? I worked 3 more shifts that week. Each night included similar incidents. Documentation appearing under my credentials that I didn't remember creating. Patients experiencing complications I had somehow anticipated in my charting before they occurred. Conversations with physicians about clinical decisions I had no memory of making. The records were always appropriate, always professionally written, always demonstrating the kind of early recognition and timely intervention that characterized excellent nursing practice. On my 4th shift, I gave handoff report to Rachel again. She reviewed the overnight documentation and asked, "Why didn't you escalate this patient's condition sooner? Your notes show you recognize the problem, but the timing seems delayed compared to when the symptoms first appeared." I looked at the flow sheet. My documentation showed I had identified a developing problem at 0300 hours, but I had no memory of the assessment, no recollection of the observations I had apparently recorded. The day nurse was critiquing my delay in responding to changes I didn't remember observing, based on documentation I didn't remember writing. "I should have acted more quickly," I said, because that was the truth the records reflected. Whatever was writing the documentation under my credentials, whatever version of myself was anticipating and describing clinical changes before they fully manifested, it was creating evidence of nursing care that was almost good enough but not quite. Care that responded appropriately but perhaps a few minutes too late, that recognized problems but could have escalated sooner, that demonstrated competence but hinted at the possibility of inadequacy. The documentation made me accountable for observations I never made and decisions I never remembered making, creating a permanent record of my practice that existed independently of my conscious experience. And the day shift nurses reviewing those records saw only what the system showed them. A night nurse whose response times could have been better, whose vigilance might have been sharper, whose care was adequate but left room for questions about why she hadn't acted sooner. I stopped trying to explain the discrepancies. I accepted the critiques embedded in handoff questions. I let the documentation speak for itself, knowing it would describe a version of my nursing practice more complete and more accountable than anything I could consciously remember providing. The records were the truth, and my memories, fragmentary, uncertain, full of gaps, were simply evidence of how much the night shift erodes your ability to trust your own mind. Some handoffs document the care you gave. Others document the care you must have given. because the system recorded it with your credentials in your handwriting using your clinical judgment, and the fact that you can't remember any of it just means you should have been paying closer attention. Story 5. Unscheduled rounds. I floated to different units depending on staffing shortages. Oncology, step down, med surge wherever the need was greatest. My badge log showed I had entered the pediatric unit at 01:45 hours and remained there for 37 minutes. I had never been assigned to pediatrics that night. I was covering a telemetry patient 5 floors away at that time. But children on the pediatric unit later referenced our conversation, quoting things I had said to comfort them, describing details about my appearance that were completely accurate. Their parents thanked me the next day. My notes documented every interaction with precision I couldn't recall experiencing. Float pool nursing requires adaptability. Instead of maintaining a consistent assignment on one unit, float nurses move throughout the hospital based on staffing needs, covering unfamiliar patients and learning new unit protocols with minimal orientation. I had worked in the float pool at Eastside Community Hospital for 7 years, building familiarity with most of the hospital's departments while maintaining the flexibility that made me valuable during understaffed shifts. My orientation folder contained competency checklists for 8 different specialty areas: medical, surgical, telemetry, intermediate care, oncology, post-surgical, orthopedics, neurology, and renal. The badge access system tracked every entry and exit throughout the hospital. Each door required a proximity scan, logging the badge holder's credentials, location, and timestamp. This security protocol served dual purposes: restricting access to authorized personnel and creating an audit trail of staff movement throughout the facility. The records were stored indefinitely, occasionally reviewed during incident investigations or when discrepancies in charting required verification of a nurse's location during specific time periods. The night of April 9th, I received a telemetry assignment. 4 patients on the 4th floor requiring cardiac monitoring and standard medical surgical nursing care. The assignment was routine for my skill level. I received report from the evening nurse at 18:45 hours, completed my initial assessments by 2000 hours, and settled into the predictable rhythm of monitoring heart rhythms and responding to patient needs. None of my patients were critically ill. All were stable enough for a night shift that should proceed without incident. At 0200 hours, I was documenting a routine vital signs check when the charge nurse approached the monitoring station. Her name was Gloria Hendricks, a veteran nurse with administrative responsibilities that kept her moving between units throughout the night. "Thanks for helping out with the pediatric situation," Gloria said, setting a tablet down on the desk. "I know you're not usually comfortable with kids, but the family really appreciated having someone sit with them." I looked up from my charting. "I haven't been to pediatrics tonight. I've been here on telemetry all shift." Gloria's expression shifted to confusion. "Your badge log shows you entered the pediatric unit at 01:45 hours. You were there for 37 minutes. I assumed you went up during a quiet period to help with the Ramirez family. I've been on this floor the entire shift. I haven't left the unit except to get supplies from the clean utility room." Gloria picked up her tablet and navigated to the security access logs. She turned the screen toward me. The display showed a chronological list of badge scans. Brennan, MRN, badge 4472, floor 4 telemetry, 1843. Brennan MRN, badge 4472, floor 4 supply closet, 2015. Brennan MRN, badge 4472, floor 4 telemetry, 2018. Brennan MRN, badge 4472, floor 9 pediatrics, 01:45. Brennan MRN, badge 4472, floor 9 pediatrics, 02:22. Brennan MRN, badge 4472, floor 4 telemetry, 02:23. Brennan was my name, Marcus Brennan. Badge 4472 had been assigned to me for 7 years. The log showed I had accessed the pediatric unit at 0145 hours and exited at 0222 hours. The timestamp indicated I had returned to the telemetry floor 1 minute later. That's impossible, I said. I was here the entire time. Check my charting. I documented vital signs on room 420 at 0200 hours. I couldn't have been on the 9th floor if I was charting on the 4th floor. Gloria pulled up the electronic health record and navigated to room 420's flow sheet. My documentation showed vital signs recorded at 0200 hours. Blood pressure, heart rate, respiratory rate, oxygen saturation. The entry was time-stamped and electronically signed with my credentials. You could have charted after you returned from pediatrics, Gloria said slowly. The timestamp might reflect when you submitted the documentation, not when you actually performed the assessment. That would be falsifying documentation, and I'm telling you I never left this unit. Gloria studied me for a moment with an expression I couldn't quite interpret. Concern, perhaps, or the beginning of doubt about my credibility. Marcus, the badge log is objective. It's not something that can be misinterpreted. You scanned into pediatrics at 0145 hours. You spent 37 minutes there. You scanned back into telemetry at 0223. I felt a cold certainty forming in my chest. Pull up the security camera footage from the pediatric unit entrance. That should show whether I actually entered. Gloria hesitated, then made a phone call to the hospital's security office. After a brief conversation, she reported that camera footage review would require a formal request through the risk management department, typically taking 24 to 48 hours to process. Let's table this for now, Gloria said. I need to continue my rounds. But if you're having gaps in your memory about where you've been tonight, that's something we need to address. It could be a fitness for duty issue. She left the monitoring station. I sat staring at the badge log on my computer screen, trying to reconstruct the past 5 hours. I remembered every patient interaction, every medication administered, every note documented. My memory of the shift was continuous and complete. I had never left the 4th floor. The badge log was wrong somehow, recording an access that never occurred. At 0300 hours, I completed another round of patient assessments. As I was documenting, a woman approached me in the hallway, middle-aged, wearing visitor clothing despite the late hour. She smiled with obvious relief. "You're Marcus, right? The nurse who was up with Emma earlier? I wanted to thank you again. She's finally asleep. I don't think she would have calmed down without your help." I stopped walking. "I'm sorry, I think you have me confused with someone else. I haven't been working with any patient named Emma tonight." The woman's smile faltered. "Emma Ramirez, on the pediatric unit. You spent almost 40 minutes with her around 2 a.m., helping her calm down after her nightmare. You told her that story about the lighthouse keeper. She kept quoting things you said. Ma'am, I work on the telemetry unit. I haven't been to pediatrics tonight." The woman's expression shifted to confusion, then mild offense. "I was there. I saw you. You were wearing exactly what you're wearing now. Navy scrubs, that badge with your name on it. You sat in the chair next to her bed and talked with her until she fell asleep. Why are you saying you weren't there?" I felt reality tilting slightly, the solid ground of my certainty becoming less stable. "What did I look like? Can you describe me?" "You look exactly like you look right now. Tall brown hair, glasses, that small scar above your left eyebrow. You had a kind voice. Emma trusted you immediately. I have a small scar above my left eyebrow from a childhood accident. The detail was too specific to be coincidence. What did I tell her? What was the story about the lighthouse keeper?" The woman recounted a story I knew well. something my grandmother had told me when I was young about a lighthouse keeper who learned that the light was most important during the darkest storms, that the act of showing up consistently mattered more than any single dramatic rescue. It was a story I had thought about often during difficult shifts, but I had never told it to anyone else. The details the woman described were completely accurate, including specific phrases my grandmother had used. "I need to check something," I said. "Excuse me." I walked to the elevator and rode to the 9th floor. The pediatric unit was dimmed for overnight hours, only a few lights still on at the nursing station. I approached the desk where a young nurse was charting. "I'm Marcus Brennan from the float pool. Can you tell me if I was on this unit earlier tonight?" The nurse looked up. "Oh yes, you were here helping with Emma Ramirez. Thank you so much for that. We were short-staffed and she was really struggling. You were great with her." "What time was I here?" "Around 1:45 to 2:20-ish. You sat with her for quite a while. Did we speak? Did I tell you why I was here or who sent me?" The nurse thought for a moment. "I don't think we had a long conversation. You just said you were available to help and asked which room Emma was in. I assumed Gloria had called you." I walked down the pediatric corridor, checking room numbers until I found the Ramirez nameplate. Through the window, I could see a young girl asleep in the hospital bed, her mother sitting in a chair beside her. I didn't enter. I didn't want to disturb them, but I stood looking at that room, trying to summon any memory of being there, of sitting in that chair, of telling my grandmother's story to comfort a frightened child. Nothing. The memory didn't exist, but the evidence was accumulating. The badge log, the mother's testimony, the nurse's confirmation, the specific details no one should have known. I had been in that room for 37 minutes. I had provided comfort and care. I had demonstrated skills with pediatric patients that I typically avoided because they made me uncomfortable. I returned to the telemetry unit and pulled up my charting for the past 4 hours. At 0150 hours, I had documented a note for room 420. Patient resting comfortably. Cardiac rhythm regular sinus. No complaints. Call light within reach. The note was detailed and appropriate, suggesting I had been present with the patient at that time. But according to the badge log, I had left the telemetry floor 5 minutes earlier and was on my way to the pediatric unit. I navigated through the entire night's documentation, checking timestamps against the badge access log. Multiple entries showed me charting on the telemetry floor during the same 37-minute period when security records placed me on the pediatric unit. I had somehow been in 2 locations simultaneously, providing nursing care in different parts of the hospital while the systems documented both sets of activities as if they were occurring in parallel timelines. Over the following weeks, the pattern continued. I would complete my assigned shift on a specific unit, maintaining continuous awareness of my location and activities. Then I would check the badge access logs and find entries showing I had visited other units during time periods I clearly remembered being elsewhere. Nurses from those units would thank me for helping with difficult situations. Patients would reference conversations I had no memory of having. My documentation would contain notes describing care provided in locations I was certain I never visited. The security office eventually provided camera footage from one instance where my badge showed access to the oncology unit while I was assigned to medical surgical 3 floors below. The video clearly showed me entering the oncology unit, walking to a specific patient room, entering for approximately 20 minutes, then leaving. My gait was distinctive. I walked with a slight favor to my right leg from an old injury. My posture was recognizable. The person on camera was unmistakably me. I requested a meeting with the float pool coordinator and the risk management director. I explained the situation as clearly as possible, documentation and badge logs showing me in multiple locations simultaneously. No memory of the additional visits, other staff and patients confirming my presence in places I couldn't recall being. I expected them to be concerned, perhaps suspicious that I was falsifying records or engaged in some kind of deception. Instead, the risk management director reviewed the evidence and concluded there was no problem. Your badge logs show appropriate activity patterns consistent with a float pool nurse helping where needed. Your documentation is thorough and professionally written. Multiple staff members have provided positive feedback about your assistance during understaffed shifts. From an administrative perspective, this demonstrates excellent initiative and collegiality. But I don't remember those interactions, I said. I have no conscious awareness of being in those locations. The coordinator smiled in a way that was probably meant to be reassuring. Marcus, you've been floating for 7 years. You're probably on autopilot for a lot of routine activities. It's not unusual for experienced nurses to have gaps in memory about specific tasks during long shifts. The important thing is that the documentation is accurate and the care is being provided. The documentation can't be accurate if I wasn't there to observe what I'm documenting. But you were there, the risk management director said patiently, gesturing to the badge logs on her computer screen. The security records confirm your presence. The camera footage shows you entering and exiting. The patients and staff corroborate your interactions. You may not remember specific details, but the objective evidence demonstrates you were present and provided appropriate care. I left the meeting feeling a strange dislocation from reality. The hospital's systems insisted I had been in multiple places, providing care I couldn't recall, documenting observations I had no memory of making. And rather than viewing this as a concerning discrepancy, administration saw it as evidence of exemplary nursing practice, going above and beyond my assigned duties to help wherever staffing needs arose. I began keeping a personal log, writing detailed notes throughout each shift about my location and activities. I would document in real time, 01:45 hours, at telemetry station, charting vital signs for room 420. Then I would later compare my personal notes to the official badge logs and find the discrepancies. Badge 4472, floor 9, pediatrics, 01:45 hours. The dual documentation continued for months. My personal record showed one continuous narrative of shift activities. The hospital system showed a different narrative, one where I moved throughout the building providing assistance to multiple units, covering gaps in staffing, helping with difficult patients. Both records were internally consistent, both were supported by evidence, but they described completely different experiences of the same night. Patients began recognizing me from previous encounters I couldn't remember. "You helped my father last month when he was on the renal unit," a family member would say. "He still talks about how patient you were." I would smile and accept the gratitude, but internally I would be searching my memory for any recollection of the renal unit, that patient, that interaction. My documentation expanded to include notes from units I had never consciously visited. I would open the electronic health record and find detailed nursing assessments attributed to my credentials. Patients I had apparently cared for, conditions I had apparently monitored, interventions I had apparently provided. The notes were professionally written, clinically appropriate, indistinguishable from the documentation I created intentionally. Except I hadn't written them, or perhaps I had in moments I couldn't remember during visits I had no conscious awareness of making. The float pool coordinator began assigning me to multiple units simultaneously. "You'll start on telemetry, but stay flexible for pediatrics if they need help," she would say during shift huddles. "And oncology might call you for assistance around midnight." The assignments seemed to assume I could be in multiple places at once, that my presence was somehow divisible across the building's various needs. And according to the badge logs, I was meeting those expectations. Night after night, the security record showed me accessing 4 or 5 different units, spending appropriate amounts of time in each location, then returning to my primary assignment. The timestamp suggested I moved through the hospital with impossible efficiency, covering distances in minutes that should have required longer travel time. I stopped trying to reconcile my memory with the documented record. I accepted that there was a version of myself moving through the hospital, providing nursing care, documenting thoroughly, building relationships with patients and families across multiple units. This version operated outside my conscious awareness but maintained perfect continuity with my professional identity. Same badge, same credentials, same clinical judgment, same characteristic way of walking that the security cameras captured. I still work in the float pool at Eastside Community Hospital. I still receive assignments that keep me moving through different units and patient populations. And I still discover evidence of care I provided in locations I never remember visiting, documented in my handwriting, confirmed by grateful families, captured on security footage that shows my distinctive gait carrying me through corridors I have no memory of walking. The badge logs track my movements with precision, showing a comprehensive record of a nurse who goes wherever he's needed, providing exactly the right care at the right time, never refusing a request for assistance even when the staffing assignments seem to require presence in multiple locations simultaneously. Some shifts are remembered, others are documented, and the hospital systems, in their perfect fidelity, maintain records that prove I was always there when needed, regardless of whether the nurse in those moments was the version of myself I consciously experience, or some other iteration that moves through the building fulfilling expectations I never knew I had agreed to meet. Story 6. Incident Report. Staff Injury. The incident report described my injury in language I would have used: laceration to the left forearm approximately 4 centimeters in length, sustained while transferring equipment between patient rooms, bleeding controlled with direct pressure, wound irrigated and dressed per protocol, no sutures required. The narrative was precise, clinical, exactly how I would document if I were objectively reporting an injury to myself. The timestamp showed the report had been filed at 03:17 hours. I wasn't injured at 03:17 hours. I was unhurt, completing my routine charge nurse duties, making rounds through the ICU, checking on staff and patients. The pain began at 07:42 hours during my drive home, when my left forearm suddenly burned with sharp intensity and I looked down to see blood seeping through my sleeve from a wound that hadn't existed 10 minutes earlier. Charge nurse responsibilities on the night shift include staff oversight, resource allocation, conflict mediation, and documentation of unusual occurrences. I had served as charge nurse for the intensive care unit at Mercy General Hospital for 12 years, developing the situational awareness required to monitor 12 critically ill patients distributed among 6 staff nurses while maintaining administrative duties that kept the unit functioning. The role required constant attention to the larger operational picture: which patients might deteriorate, which nurses might need assistance, which physicians required updates, which equipment required maintenance. Incident reporting was a routine component of charge nurse documentation. Any significant event, patient fall, medication error, equipment malfunction, staff injury, required a formal report submitted through the hospital's risk management system. The reports followed a standardized format: date and time of incident, location, individuals involved, factual description of what occurred, immediate actions taken, notifications completed. The reports were reviewed by risk management and used to identify patterns requiring systemic intervention. I had filed hundreds of incident reports over 12 years. The process was familiar enough to be automatic. Objective documentation of facts without speculation or blame. Focus on the sequence of events and the response rather than attempting to explain why something occurred. The tone was clinical, detached, the same narrative voice I used for any professional documentation. I could recognize my own writing style in incident reports the same way I could identify my handwriting. Characteristic phrase structures, specific vocabulary choices, consistent attention to certain details. The night of May 17th began routinely. I arrived at 18:30 hours to receive report from the evening charge nurse. The ICU census was 11 patients with 1 available bed. Staffing was adequate. 6 nurses plus myself. Each nurse assigned 2 patients except for the most junior nurse who had a single complex case. The overnight intensivist was Dr. Ellen Park, an experienced critical care physician who had worked with me many times. I made initial rounds through the unit at 19:30 hours, checking in with each nurse to assess their comfort level with their assignments and identify any anticipated issues. Everything appeared stable. No patients were actively deteriorating. No equipment issues had been reported. The evening had the calm atmosphere that sometimes precedes busier overnight hours but occasionally persists through an entire shift. At 2100 hours, I was completing administrative documentation at the charge nurse station when the unit secretary handed me a sealed envelope from the risk management office. "This came up through internal mail," she said, "marked urgent for your attention." I opened the envelope. Inside was a printed incident report with a sticky note attached. "Please review and confirm accuracy of details. File in staff health records per protocol. Risk management." I read the incident report. The header showed it had been submitted through the electronic system at 03:17 hours, 5 hours in the future. The report documented a staff injury. Date, May 17th. Time of incident, 03:17 location, ICU, between room 7 and central supply staff member. Injured, R. Morgan, RN, charge nurse, nature of injury, laceration to left forearm, approximately 4 centimeters in length, extending from mid-forearm to 2 centimeters distal to antecubital fossa. Description: staff member was transferring portable monitoring equipment between patient rooms when equipment cart shifted unexpectedly, causing loss of balance. Staff member reached out to stabilize against door frame of room 7. Left forearm made contact with exposed metal bracket protruding from door frame, resulting in linear laceration. Immediate bleeding noted. Staff member applied direct pressure with clean gauze. Wound irrigated with normal saline. Bleeding controlled within 5 minutes. Wound edges approximated, no gaping noted. Dressing applied per standard protocol. Staff member reports tetanus immunization current. Wound does not require sutures. Staff member able to continue duties with modified assignment, avoiding heavy lifting. Notifications: unit manager notified, staff health notified, maintenance work order submitted for removal repair of protruding bracket on room 7 door frame. Report submitted by R. Morgan, RN. R. Morgan was my name, Rachel Morgan. I held my left forearm up, examining it in the fluorescent light of the nursing station. The skin was intact, unmarked, no laceration, no bandage, no sign of injury. I wasn't transferring equipment. I was sitting at the charge nurse desk completing routine documentation. I hadn't approached room 7 in the past hour. I checked the timestamp on the report again. 03:17 hours. The current time was 21:15 hours. The report described an injury that hadn't occurred yet, documented with clinical precision in the same narrative style I used for all incident reports. The description was thorough, Wound measurements, bleeding control methods, decision-making about suture requirements. Details I would absolutely include if I were objectively documenting my own injury. I walked to room 7 and examined the door frame. There was no protruding metal bracket, no obvious hazard that could cause the type of laceration described in the report. The door frame was smooth, the metal trim properly installed and flush with the wall. I returned to the charge desk and pulled up the electronic incident reporting system. I navigated to the submitted reports queue and searched for entries from my credentials. The most recent report showed a submission at 0317 hours, the same report I held printed in my hand. According to the system metadata, I had completed and submitted the report approximately 6 hours in the future. I felt a familiar cold weight settling in my chest, similar to sensations I had experienced during previous night shifts when documentation appeared before the events it described. The incident report was real, filed in the official system, awaiting my confirmation of accuracy. But the injury hadn't occurred. I was unharmed, sitting safely at the charge desk, with no immediate plans to transfer equipment or approach room 7. I made a decision not to share the report with anyone yet. I folded it and placed it in my pocket, then returned to routine charge nurse duties. Over the next several hours, I deliberately avoided room 7, stayed away from portable equipment carts, and maintained careful awareness of my physical position and activities. I was determined to prevent the injury the report had documented in advance. At 0200 hours, Dr. Park approached the charge desk with a request. "Rachel, we need to move the portable ultrasound from room 7 to room 11. Mr. Brennan needs an evaluation for possible fluid overload. Can you help me transport it? The machine is heavy and I don't want to risk dropping it." I felt a spike of alertness. Room 7, portable equipment, exactly the scenario described in the incident report. "I can ask one of the nurses to help you," I said. "Everyone else is occupied right now. It'll just take 2 minutes. The machine is already disconnected and ready to move." Dr. Park was an attending physician. Refusing her reasonable request would require explanation I wasn't prepared to provide. I stood up and followed her to room 7. The portable ultrasound machine sat on a wheeled cart beside the patient's bed. Dr. Park positioned herself at one end of the cart. I took the other end. We guided the cart out of the room and down the corridor toward room 11. The cart moved smoothly. No unexpected shifts, no loss of balance. We reached room 11 without incident and positioned the ultrasound for the requested examination. I helped Dr. Park set up the equipment, then returned to the charge desk. My left forearm was intact. No injury, no pain, no bleeding. Whatever the incident report had documented apparently hadn't occurred despite my involvement in exactly the scenario it described. At 0300 hours, I was charting at the charge desk when I heard a crash from the direction of the central supply room. I stood quickly and walked toward the sound. One of the nurses, Jenny Hartford, was standing outside room 7 looking at a portable monitoring cart that had tipped over, spilling supplies across the floor. "I'm so sorry," Jenny said. "The cartwheel caught on something and it just went over. Nothing broken, I think." I helped her right the cart and collect the scattered supplies. As we were working, I noticed the doorframe of room 7. A small section of the metal trim had pulled away from the wall, creating a sharp edge that protruded about 2 centimeters into the corridor. The edge was at approximately forearm height. "Did you see this?" I asked Jenny, pointing to the protruding metal. "Oh, that's dangerous. That must be what caught the cartwheel. Someone could get hurt on that." I stepped carefully around the hazard and continued helping clean up. We restacked the supplies on the cart and Jenny wheeled it toward the central supply room. I walked to the charge desk to submit a maintenance request for the damaged doorframe. As I reached for the computer, I felt a sudden burning sensation on my left forearm. I looked down and saw blood seeping through my sleeve. I pulled up the fabric and found a linear laceration approximately 4 centimeters long, extending from mid-forearm to just below the antecubital fossa. The wound was bleeding steadily. I had no memory of hitting my arm against anything. No awareness of the moment of injury. Just the sudden appearance of a wound that matched exactly the description in the incident report filed 6 hours earlier. I walked quickly to the supply cabinet and gathered clean gauze. I applied direct pressure to the wound. The bleeding slowed within minutes. I irrigated the wound with normal saline and examined the edges. Clean, linear, no gaping. Unlikely to require sutures. I applied an appropriate dressing and secured it with tape. The current time was 03:17 hours. Exactly the timestamp on the incident report. I pulled the printed report from my pocket and read through the description again. Every detail matched. Wound location, approximate length, bleeding controlled with direct pressure, irrigation with normal saline, determination that sutures weren't required. The report had documented my injury with complete accuracy 6 hours before it occurred, using the same clinical language and observational precision I would employ if I were reporting on myself as a detached observer. I sat at the charge desk and submitted a work order for maintenance to repair the protruding metal bracket on Room 7's doorframe. I notified the unit manager via email about the staff injury. I called staff health and left a message describing the incident and confirming my tetanus immunization was current. I completed all the notifications listed in the incident report that had been submitted in my name hours earlier. Then I opened the electronic incident reporting system and navigated to the report filed at 03:17 hours. I read through the narrative again, noting the precise correspondence between the documented description and the injury I was now experiencing. The system prompted me to confirm the report's accuracy and add any additional details. I clicked the confirmation button. The system acknowledged my review and closed the report, filing it in my permanent staff health record. I continued my charge nurse duties for the remainder of the shift. The dressing on my forearm remained clean and secure. The wound throbbed with steady pain that intensified when I moved my arm, but the discomfort was manageable. I modified my activities slightly, avoiding heavy lifting exactly as the incident report had documented I would do. At 06:45 hours, I gave report to the day shift charge nurse. I mentioned the injury briefly, explaining that I had filed the appropriate incident report and completed all required notifications. She examined the dressing and agreed the wound appeared minor and well managed. I clocked out at 0700 hours and walked to the parking garage. The morning was cool, the sun just beginning to rise. I drove toward home with my left arm resting carefully on the steering wheel, aware of the injury's presence in a way that made every movement slightly different from routine. At 0742 hours, while stopped at a traffic light 3 blocks from my apartment, I felt the pain in my forearm suddenly intensify. The burning sensation that had been present since 03:17 hours became sharp, immediate, as if the injury were occurring for the first time. I looked down at my arm and saw fresh blood seeping through the dressing, saturating the gauze. I pulled into a parking lot and carefully removed the dressing. The wound edges had separated slightly. What had appeared to be a clean linear laceration at 03:17 hours now looked deeper, the tissue damage more extensive. The injury seemed to be worsening rather than beginning its normal healing process. I applied fresh gauze and pressure. The bleeding slowed but didn't fully stop. I drove the remaining distance to my apartment and immediately re-washed and redressed the wound. The pain continued to intensify throughout the morning, becoming sharp enough to interfere with my attempts to sleep. By noon, I recognized the wound was not behaving like a typical minor laceration. I called my primary care physician and described the injury. She asked me to come in for evaluation. At the appointment that afternoon, she examined the wound and noted signs of infection despite the injury being only 12 hours old. She prescribed antibiotics and advised me to keep the wound clean and covered. "This doesn't look like a fresh injury," she said, studying the wound edges. "The tissue breakdown suggests this might have occurred days ago rather than last night. Are you certain about the timing?" I was certain about the documented timing, 0317 hours. But I was no longer certain about when the actual injury had occurred. The incident report had been submitted 6 hours before I became aware of the wound. The pain had intensified at 0742 hours, more than 4 hours after the initial documentation. The wound appeared to be aging at an accelerated rate, progressing from fresh laceration to infected injury within hours. "The timing is complicated," I said. Over the following week, the wound followed an unusual healing trajectory. Some days it appeared improved, the edges beginning to close. Other days it looked worse, the tissue inflamed and drainage increasing. The pain fluctuated unpredictably, sometimes barely noticeable, sometimes sharp enough to require medication. My physician eventually referred me to a wound care specialist who noted that the injury showed characteristics of wounds at different healing stages simultaneously, as if the laceration were aging through multiple timelines at once. The incident report remained in my staff health file, documenting with clinical precision the injury I had sustained at 0317 hours on May 17th. The report's accuracy was never questioned. The maintenance work order for the protruding metal bracket was completed 2 days after the incident. The bracket's sharp edge was filed smooth and the trim properly secured. Evidence of the hazard was preserved in photographs taken by the maintenance department, showing exactly the kind of metal protrusion that could cause the linear laceration described in my incident report. I returned to work after the wound sufficiently healed to allow unrestricted duties. I continued as charge nurse on the night shift, resuming the familiar routine of staff oversight and administrative documentation. And occasionally during quiet overnight hours, I would check the incident reporting system and find new reports filed under my credentials documenting staff injuries or equipment malfunctions that hadn't yet occurred, using clinical language I recognized as my own, describing events with the precise detail I would employ if I were objectively reporting on situations I had perfect knowledge of before they happened. The system maintained these reports, filing them appropriately, generating work orders and notifications, creating a permanent record of incidents that proceeded exactly as documented once the proper timestamp arrived. Sometimes I would try to prevent the incidents by avoiding the described circumstances, staying away from specified locations, declining to handle particular equipment, altering my routine to eliminate the scenario the report anticipated. But the incidents would occur anyway. The injuries would manifest. The equipment would malfunction. Reality would conform to the documentation with enough fidelity that no one questioned the report's accuracy, even when I had read the detailed descriptions hours or days before the events actually happened. I learned to accept the incident reports as inevitable rather than preventable. When I found a report documenting a future injury, I would prepare myself for the eventual pain, gather the supplies I would need for wound care, arrange for the time off that might be required for healing. The reports became a form of advance warning, allowing me to prepare for injuries I couldn't prevent but could at least anticipate. Some documentation describes what happened. Other documentation describes what will happen, written by a version of yourself with perfect foresight into the moments you haven't yet experienced. And the only way to confirm the accuracy of that documentation is to wait until the proper time arrives and discover that your body, Your pain, your bleeding wound all conform exactly to the clinical narrative filed under your credentials hours before you became conscious of any injury at all. The report documents the truth, and your subsequent experience simply validates what the system already recorded. Your memory of being uninjured, your certainty that no laceration existed, these are temporary states that will be corrected once reality catches up to the permanent record maintained by the hospital's meticulous documentation of every incident involving every staff member working every shift, recording with perfect fidelity not just what has occurred, but what must occur to make the documentation remain accurate, to keep the reports true, to ensure the system's integrity regardless of your conscious experience of time, injury, or the sequence of events that begins with documentation and ends with the wound that proves the paperwork was always right. Story 7. Clock out confirmation. The timekeeping system confirmed I had clocked out at 0700 hours. I received the automated email notification thanking me for completing my shift and reminding me of my next scheduled workday. My electronic time card showed departure logged, badge deactivated for facility access, another night completed. Except I was still walking the halls of the geriatric ward, still checking on Mrs. Whitmore in room 518, still wearing my badge that continued to open locked medication rooms and restricted corridors. I stood at the clock-out terminal and saw my own entry. Morgan Patricia RN. Departure 07 Zatter, status complete, but my shift wasn't complete. I was still here, still working, still providing care the system had apparently stopped documenting. Geriatric ward nursing requires patients experiencing confusion, dementia, and the gradual dissolution of the personalities they once possessed. I had worked the geriatric ward at Riverside Community Hospital for 14 years, developing tolerance for repetitive questions, comfort with residents who no longer recognized their own children, and acceptance that most of my patients were approaching death rather than recovery. The work was emotionally taxing but possessed a certain rhythm. Predictable patterns of decline, established routines of care, the quiet dignity of helping people through their final chapters. The clock-out terminal was located near the nursing station, a wall-mounted screen with a badge scanner and fingerprint reader. The system required both forms of authentication to clock in or out, creating a verifiable record of each employee's hours. The terminal displayed real-time confirmation when you clocked out, your name, the departure time, and a brief message. Thank you for your service today. Your next scheduled shift is date and time. The system would then send an automated email confirmation to your personal account within 5 minutes. Clock out represented a psychological boundary as much as an administrative requirement. The act of scanning my badge, pressing my thumb to the reader, and seeing the confirmation message represented the transition from professional responsibility to personal time. After clocking out, I was no longer on duty, no longer accountable for patient care, no longer required to respond to call lights or emergencies. The building could continue functioning without me. Other nurses would assume responsibility for the patients I had cared for during my shift. The night of June 8th followed its usual pattern. I arrived at 1845 hours, clocked in, received report from the evening nurse. The geriatric ward held 32 residents distributed across 16 rooms. Most were long-term placements with chronic conditions requiring ongoing care rather than acute interventions. My assignment included 8 residents, all familiar to me from previous shifts. Mrs. Whitmore in room 518 had moderate dementia and would likely ask me the same questions multiple times throughout the night. Mr. Peterson in room 522 had advanced Parkinson's disease and required assistance with all activities of daily living. Mrs. Chen in room 524 was recovering from a hip fracture, mentally sharp but physically frail. The night proceeded through its established routine: medication administration at 2000 hours, position changes every 2 hours for immobile residents, response to call lights, assistance with bathroom needs, comfort measures for those experiencing pain or anxiety. By 0300 hours, most residents were sleeping. The hallways were quiet except for the soft sounds of breathing and the occasional murmur from someone dreaming. At 0600 hours, I began preparing for shift change. I completed final documentation, reviewed notes for the incoming day shift nurse, gathered my personal belongings from my locker. By 0650 hours, I was ready to give report and clock out. The day nurse arrived a few minutes early and we walked through the patient assignment together, discussing each resident's overnight status and any issues requiring follow-up. At precisely 0700 hours, I walked to the clock-out terminal. I scanned my badge. The familiar confirmation appeared on the screen. Morgan, Patricia RN, departure 07 door. Status complete. Thank you for your service today. Your next scheduled shift is June 9th, 19 Gots. I pressed my thumb to the fingerprint reader for secondary authentication. The system beeped its acknowledgement. The screen showed my shift officially closed. I turned away from the terminal and walked toward the elevator. As I passed room 518, I heard Mrs. Whitmore calling out in distress. I stopped walking. Mrs. Whitmore had been sleeping peacefully when I had checked on her during final rounds 15 minutes earlier. The day nurse was still receiving report from another colleague in a different section of the ward. I was the only staff member immediately available in this corridor. I entered room 518. Mrs. Whitmore was sitting up in bed, breathing rapidly, her expression frightened. "I can't find my mother," she said urgently. "She was supposed to meet me here. Have you seen her?" Mrs. Omarudus Whitmore's mother had died 23 years earlier. This was a frequent concern for Mrs. Whitmore during periods of increased confusion. The appropriate response was gentle reorientation and comfort rather than confronting her with the reality of her mother's death. "Your mother would want you to rest right now," I said gently. "Let's get you comfortable again." I helped Mrs. Whitmore lie back down, adjusted her pillows, and spoke soothingly until her breathing slowed and the fear left her expression. Within a few minutes, she was calm again, her eyes beginning to close. I stayed with her until she fell asleep, then quietly left the room. I walked toward the elevator again. As I approached the nursing station, I saw my badge still displayed on my scrub pocket. I tried to scan it at the medication room door, a reflexive action from years of accessing that room dozens of times each shift. The door unlocked with its characteristic click. The system had accepted my badge credentials. I felt a subtle disorientation. I had clocked out. My departure was officially logged, but my badge continued to function, granting me access to restricted areas that should be inaccessible once a shift was completed. I approached the clock-out terminal again and looked at the screen. It displayed the standard interface showing recently completed clockouts. My name was listed: Morgan Patricia RN, departure 07 Sir, status complete. The current time shown on the terminal was 0717 hours. According to the system, I had left the building 17 minutes ago. I pulled out my phone and checked my email. The automated clock-out confirmation had arrived at 0703 hours. "Thank you for completing your shift ending June 8th, 07 Lugo. Your time card has been updated. Your next scheduled shift begins June 9th, 19 Silo. Please ensure adequate rest between shifts." I walked to the nursing station where the day nurse was now reviewing charts on the computer. She looked up as I approached. "I thought you left," she said. "I clocked out, but I'm still here. Mrs. Whitmore needed assistance." The day nurse frowned slightly. You shouldn't be providing care after you clock out. That's a liability issue. If something happens while you're technically off duty, the hospital's coverage might not apply. I know. I'm leaving now. I walked to the elevator and pressed the call button. The elevator arrived and I stepped inside. As the doors were closing, I heard a call light alarm from the corridor I had just left. The distinctive chime indicating a resident required assistance. The day nurse would respond. I was off duty. My shift was complete. The elevator descended to the ground floor. I walked through the main lobby toward the exit. My badge hung from my scrub pocket, visible to anyone who looked. No one stopped me. The security guard at the front desk nodded as I passed. "Have a good morning, Patricia," he said. I pushed through the glass doors into the morning sunlight. The parking lot was beginning to fill with arriving staff and early visitors. I walked toward my car, then stopped. Something felt incomplete. A persistent sense that I had forgotten an important task, left something undone. I turned and looked back at the hospital building. The geriatric ward occupied the third floor, its windows reflecting the morning sky. I thought about Mrs. Chen, who would need assistance getting to the bathroom when she woke. About Mr. Peterson, who would require help with his breakfast. About Mrs. Whitmore, who would forget our recent interaction and ask again about her mother. The day shift would handle all of it. They were competent nurses. The residents would receive appropriate care. My shift was over, but I walked back toward the building anyway. Some instinct or habit was pulling me back. I scanned my badge at the entrance. The door unlocked. Inside, I headed toward the elevator. The security guard looked up from his desk. "Forget something?" he asked. "Need to check on one of my residents," I said. The elevator carried me back to the third floor. I walked the familiar corridor toward room 518. Mrs. Whitmore was sleeping peacefully. I checked her vital signs out of habit. Heart rate steady, breathing regular, no signs of distress. I adjusted her blanket and left the room quietly. As I passed the nursing station, the day nurse called out, "Patricia, you're still here? Your shift ended an hour ago." I looked at the clock on the wall. 0800 hours. An hour had passed since I clocked out. I had been walking the hallways, checking on residents, performing tasks that were no longer my responsibility. "I'm leaving now," I said. I walked to the elevator again, rode down to the lobby, crossed to the exit, pushed through the glass doors, walked toward my car. The sun was higher now, the parking lot more crowded. I reached my vehicle and stood with my hand on the door handle, trying to overcome the persistent feeling that my shift was incomplete. I checked my phone. The clock-out confirmation email was still there, time-stamped 0703 hours. More than an hour ago. The hospital's timekeeping system recorded my departure as complete. I was officially off duty. I got into my car and started the engine. Drove out of the parking lot. Turned onto the main road heading toward my apartment. At the first traffic light, I glanced at my passenger seat and saw my bag containing my work shoes and lunch container. Evidence that I had completed my shift and was heading home. At the second traffic light, my phone chimed with a message from the hospital's automated system. "Reminder, you are currently clocked in. Please remember to clock out at the end of your shift to ensure accurate time card records." I pulled over and read the message again. I had clocked out at 0700 hours. I had seen the confirmation. I had received the email. But the system was now indicating I was still clocked in, still on duty, still accumulating hours. I called the hospital's human resources hotline and explained the situation. The representative pulled up my time card records. "Ms. Morgan, your current status shows you clocked in yesterday at 1845 hours. No clock-out time is recorded. You're currently on an active shift that's been running for 14 hours and 27 minutes. I clocked out at 0700 hours this morning. I saw the confirmation on the screen. I'm not seeing that in the system. Your badge shows continuous facility access throughout the morning, including door scans on the 3rd floor as recently as 15 minutes ago. According to our records, you're still at work. I felt reality becoming unstable, the solid facts of my completed shift dissolving into contradiction. Check your email logs. The system sent me a clock-out confirmation at 0703 hours. The representative was silent for a moment, presumably checking records. Ms. Morgan, I show no automated email generated for your account this morning. The last clock-out confirmation we sent you was June 7th at 0700 hours, yesterday's shift. That's not possible. I received the email. I can forward it to you. Please do that. In the meantime, I need to advise you that if you've left the facility without clocking out, this constitutes a timekeeping violation. You need to return to the hospital immediately and properly clock out to avoid disciplinary action. I ended the call and checked my email again. The clock-out confirmation from 0703 hours had disappeared. My inbox showed the most recent automated message as June 7th, yesterday's shift, exactly as the human resources representative had indicated. I looked at my reflection in the car's rearview mirror. I was still wearing my scrubs. My badge was still clipped to my pocket. I appeared exactly as I had when I walked out of the hospital 30 minutes earlier. But according to the hospital's systems, I had never left. I was still on duty, still responsible for patient care, still physically present in the building, even though I was sitting in my car several miles away. I drove back to the hospital, parked in my usual spot, walked through the main entrance. The security guard looked up. "Patricia, I thought you left." "I tried to," I said. I rode the elevator to the 3rd floor. The day nurse saw me approaching and shook her head. "You really need to go home. You've been here all night. You're going to exhaust yourself." I clocked out. The system says I didn't. I walked to the clock-out terminal. The screen displayed the standard interface. I scanned my badge. The system showed Morgan Patricia RN. Status currently clocked in. Time elapsed 14:47. Please confirm clock-out time. I pressed the confirmation button. The screen showed Departure 0932. Status complete. Thank you for your service today. Your next scheduled shift is June 9th, 1900. I stood looking at the screen. The departure time showed 0932 hours. The current time more than 2 hours after my original clock out that the system no longer acknowledged. My time card would reflect a shift lasting 14 hours and 47 minutes, nearly double the actual duration. I left the hospital again, drove home, slept restlessly through the afternoon. When I woke at 1600 hours, I checked my phone. Another automated message from the hospital. Reminder, you are currently clocked in. Please remember to clock out at the end of your shift to ensure accurate time card records. I called Human Resources again. A different representative answered. I explained the situation, clocking out repeatedly, the system not recording my departure, the continuous messages indicating I was still on duty. Ms. Morgan, I'm showing you clocked out at 0932 hours this morning. Your shift is complete. I'm not sure why you're receiving clock-in reminders. That sounds like a system glitch. I'll submit a trouble ticket to IT. What about my original clock out at 0700 hours? I don't see any record of that. Your departure is logged at 0932. I ended the call and opened the hospital's employee portal on my laptop. My time card showed June 8th with clock in at 1845 hours and clock out at 0932 hours. Total shift duration, 14 hours, 47 minutes. No indication of the earlier departure I had witnessed on the terminal screen. No evidence of the automated email that had briefly existed confirming my 0700 hours clock out. The following night, I arrived for my regularly scheduled shift at 18:45 hours. I clocked in without incident. The night proceeded routinely. At 0700 hours, I completed my patient care, gave report to the day nurse, and approached the clock-out terminal. I scanned my badge. The screen confirmed, Morgan, Patricia RN, departure 07 ZARS, status complete. I left the building and walked to my car. Before starting the engine, I checked my phone. The automated email arrived at 0704 hours. I drove away from the hospital, periodically glancing at my phone for any indication that the system still considered me on duty. No messages appeared. The clock-out seemed to have processed correctly. At 0800 hours, while I was stopped at a traffic light near my apartment, my phone chimed. The hospital's automated system. Reminder, you are currently clocked in. I pulled into my apartment parking lot and called Human Resources from my car. The representative confirmed what I already knew. The system showed me as currently on duty. No clock-out recorded, continuous facility access logged throughout the morning. This is the second time this has happened, I said. There's clearly a problem with the timekeeping system. I'll escalate this to IT with high priority. In the meantime, you need to return to the hospital and clock out properly. I drove back to the hospital. Clocked out at 0833 hours. The system confirmed my departure. I received the automated email. I drove home again, successful this time in completing the transition from work to rest. But over the following weeks, the pattern continued. Some shifts I would clock out without issue. Other shifts, the system would refuse to acknowledge my departure no matter how many times I scanned my badge and confirmed my clock out on the terminal screen. The hospital's records would show me on continuous duty, accumulating hours through times when I was verifiably at home sleeping. My badge would continue functioning, granting facility access during periods when I was officially clocked out. Automated reminders would arrive telling me to clock out for shifts that were already documented as complete. The IT department investigated and found no technical explanation. The timekeeping system functioned properly for all other employees. Only my account demonstrated the irregular behavior. Clockouts that disappeared from the record. Shift durations that extended beyond the hours I had actually worked. System status that contradicted my physical location. Eventually, the hospital's human resources director called me for a meeting. She explained that the timekeeping irregularities combined with reports from other staff that I had been observed on the unit during hours when I was supposedly clocked out raised concerns about my awareness and reliability. She suggested I consider a medical evaluation and temporary leave of absence. I accepted the leave. The alternative was to continue arguing that I was clocking out properly when the system's records increasingly suggested otherwise, to insist that I was leaving the hospital when my badge continued accessing locked doors and other staff continued seeing me in the corridors. To claim that my shifts ended when the timekeeping system maintained evidence of my ongoing presence hour after the moment I thought I had crossed the threshold from responsibility to rest. During my leave, I would sometimes drive past the hospital late at night, and I would think about Mrs. Whitmore calling out for her mother, about Mr. Peterson needing assistance, about Mrs. Chen waiting for someone to help her to the bathroom. I would think about the geriatric ward continuing its routine of care, the night nurses moving through their predictable patterns, the residents sleeping or waking in rooms I had walked through thousands of times. And I would wonder if some version of myself was still there, still working, still providing care that the system documented with my badge scans and time card entries that accumulated hours I never consciously experienced. Still showing up for shifts that never quite ended, clockouts that never quite completed. Departures that were confirmed and then revoked and then confirmed again in an endless cycle of attempted transitions from duty to rest that the system, or the hospital itself, seemed unwilling to finalize. Some shifts end when you clock out. Others apparently continue indefinitely, documented by systems that track your presence with perfect accuracy regardless of where you believe you are, confirming your ongoing responsibility for patients you thought you had transferred to other nurses' care. The clock-out terminal shows its message, status, complete, and you believe it. You walk away, you drive home. You sleep, but the hospital knows better. The hospital records the truth. Your shift isn't over until the system stops logging your badge scans, stops generating reminders, stops sending you back to clock out one more time in the hope that eventually, after enough attempts, the departure will finally register as permanent rather than just another temporary absence that will inevitably draw you back to the hallways you thought you had left, to the residence you thought you had handed off, to the care you thought had transitioned to someone else but apparently remains your responsibility throughout every hour. The timekeeping system continues to document your presence whether you're conscious of being there or not.